Okay. No, it's still 9:59. Here we go, 10 o'clock. Good morning, everyone. This is the Adults and Health Committee of Cambridgeshire County Council. It's the 27th of June, and welcome to all of the members to the meeting. I'd like to particularly welcome two new members to the committee. One returning member, as she tells me, since the annual meeting. That's Councillor Keith Prentice and Councillor Simone Taylor. You're very welcome at the meeting. Thank you very much for joining us, and please contribute as much as you choose in the meeting. I've also got a pleasant but also slightly sad announcement that Donna Glover on my right-hand side at the back there, who's our Service Director for Adults in the Directorate working directly to Patrick, has recently been appointed as the Director of Adult Social Services at Bromley. And I have to say, although it's a hugely sad moment, I think, for me and for us, it is very well deserved. You are a brilliant social worker. You've done absolutely outstanding service for us. And I know that you're director level, and I'm not surprised at all, actually, that you've been appointed by them, and I wish you well. And I'm sure we'll see you still at some of the conferences and meetings and so on. But for other members of the committee, and for the new members in particular, Donna has been in charge of all of our work with under 65s across the whole range. She's been absolutely instrumental in our work on workforce and setting up the Care Academy, which we couldn't have done without her, and is a huge legacy to your work. You've been helping us deal with the really thorny issues on the Learning Disabilities Partnership, which has been really hard. You've been helping us deal with the hospital discharge issues. And you are the first person who was able to explain providers of concern to me in a language that I actually could understand. And that was really an early moment in your and my communications with each other, but shows that you're really sensitive to making things meaningful and understandable to people in the Directorate, to us as politicians, but also to service users. So thank you so much for what you've done, and we wish you very well in the future. I'm also going to read out the notes that we're always required to read out, so I'll do that next, which is that we allow filming, photography. Feel free to take pictures, use social media, as long as it doesn't interrupt the proceedings in any way or disrupt them. Please, everyone, all of us, turn off our mobile phones or turn them to silent or vibrate while the meeting is taking place. I'm like an airport steward that's doing it myself now to demonstrate what we need you to do. Be aware that the meeting is being live streamed, and that recording of the meeting will be able to be viewed on the County Council's website. When you wish to speak, please raise your hand. I will adjourn the meeting after no more than 2 hours for a comfort break. There's no fire alarm test scheduled for today. So if the alarm sounds, I'll immediately adjourn the meeting, and we will leave via the fire escape, which is situated halfway along the corridor, and you use those doors on your left in order to get to it, to use the external stairs, and we would assemble in the car park. It may not have escaped your notice that there's a general election on at the moment, and I'm sure you will have read emails which describe the advice of our monitoring officer about the conduct of meetings during the election period, which I fully endorse and intend to implement this morning. And what that means, folks, is can we all, including me and my group, all exercise self-discipline? We're here to do essential council business only. And can we try and refrain from points which could be interpreted as trying to affect the party political climate at the moment? That won't stop me allowing questions of scrutiny of our officers and of papers. You know, that's our role here. But we all know there's a line there. And I'm asking people to make sure that you stay on the right side of the line. This has been discussed between myself, Councillor van der Ven and Councillor Bowden and Councillor Taylor at the spokes meeting. We're all in agreement. So can all of us exercise self-discipline And I will just say in advance that point D, section 4 of the Constitution on disorderly conduct enables me to shut you up and indeed eject you from the meeting if you choose not to comply with that. And I will, if someone is flagrant in abusing that, I will have no hesitation in using that power. But I don't believe that that's going to happen, because I believe that you're going to all be cooperative on that front. That is Chair's introduction. I now move to item 1, constitutional matters, and that's simply to note that Councillor Van der Ven and myself have been elected Vice Chair and Chair of the Adults and Health Committee at the annual meeting. Is that noted? Yes, it is. Next, we have apologies for absence. Tamar, please.
Apologies received from Councillor Reynolds and Councillor Steve Corney.
Thank you very much. Any others that anyone knows about? I can also confirm that I've got to read this in for the record. Sorry, folks. I have to just put on the record that Councillor Cameron Holloway is replacing Councillor Rachel Wade as the co-optee from Cambridge City Council. But our co-optees are obviously not joining us today because the health scrutiny section was removed following the monitoring officer's advice. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? I see none. We move to item 3, the minutes of the Adults and Health Committee from the 7th of March 2024. Those are on page 5 to 32 of your agenda pack. Are they agreed as a correct record? I'm seeing nods. Can I just check? Am I seeing nods on the right-hand side? It's all one. Yep. Any disagreement? No. So I'm going to sign those. They are agreed. Right. An updated action log is included on pages 25 to 32 of the agenda pack. Any questions or points? Councillor Black.
Thank you very much, Chair. I mean, it strikes me in these meetings that when we have these agenda logs, and it seems very difficult to keep up with what's happening in the here and now, because the elephant in the room, as far as health is concerned at the moment, is that this morning the junior doctors in the BMA are going on strike. And I think that's amazing. You think I'd like us to send a message of solidarity with them, because I think you can see the end of this dispute coming.
I'm really sorry, Councillor Black, but whatever sympathy I do or don't have with what you say, I'm going to rule that I'm afraid transgresses the line in terms of essential council business. I have sympathy with your wish to address the point, but I'm not going to allow you to continue that. And I'm sorry, I asked you to put your microphone off, and I asked no other member to come back. I'm going to. Yes, I asked no other member to come back. Oh, it's a different point on the action log. I do apologise, Councillor Seif.
Thank you, Chair. Good morning, everybody. I don't know if it's actually in the action log per se, but it's in the minutes, and sorry, I can't find it in the action log. But it's just following up on I think it's on page 6, where the public health risk concerning right care, right person. I believe that phases 2 and 3 of the plan were due to be implemented during May, and there were apparently a number of issues to be resolved. And I wondered how we got on with that. So perhaps I can ask Patrick.
Thank you, Patrick.
Yeah, thank you, Chair. It was being paused during the general election run-up. So we've got time in the diary early July, after the 4th, where we will be, I think what we're describing it as a walkthrough. So we're doing phase 2 and 3, which is absent without leave. So people leaving hospital who are detained, but also people who are detained under Section 136 of the Mental Health Act will be we'll be doing that with our partners and working through just to understand the implications of that. Other parts of the council, of the country, sorry, have implemented phases 1, 2, and 3. So we're also learning from them. But yeah, the May date was slipped and paused whilst the general election concluded.
Thank you. I've got Councillor Costello next, then I'll take Councillor Staunton. Councillor Costello, please.
Yes, it's on page 26. It's our request of forecast date of the proposed North Norwich University Hospital.
I'm not hearing you too well. Could you bring the microphone just a little bit closer? Thank you so much.
Shall I repeat myself?
Yes, please.
Did you not hear me? Sorry. Yes, it's on page 26. It's about our request for forecast data on the number of patients to be seen by the proposed North Norwich University Hospital. This has been ongoing for over a year now, and we've put in requests and reminders and everything. I just wondered where we are now and what is the likelihood of this being resolved at some time.
Could I just say, when I read this, I was amazed. It's almost embarrassing, isn't it? But
Yeah.
It's not the fault of our officers, who you can see have diligently done it, but it's amazing. And I felt that when I read it. Who would like to come back on that?
I know that's something Rishenda's following up. She's been following up. Rishenda, who supports scrutiny.
Yeah, but I'm going to look at one of Val or Patrick. This is not really on to just not get basic information for over a year, is it? Val.
I agree. It's difficult when you've asked for information and it's been quite a long period without a result. We could talk to Rishenda and actually see who she's spoken to and follow it up and try and push it.
I am grateful for that. Rishenda's not here, and I'm sure, as you can see, has done a lot. So if you can support
Yeah,
her
I'll
trying
talk
to
to
break through so we get something by the next meeting, that would be great. Thank you to Councillor Costello. Councillor Staunton.
Yes, my question was almost identical to Councillor Costello's. That's why I wanted to make sure I heard what you were saying. I would just add to that on the list here in front of us, an update was requested at the liaison group meeting, and that was in January. So I wonder if there'd been another liaison group meeting since then, and if not, when the next liaison group meeting actually takes place, could it not be raised at that point?
Councillor Van de Ven is a member of that liaison group, so may be able to answer that in Rishenda's absence.
Yeah, I'm aware that the liaison dates are being arranged at the moment, but it is incredibly difficult job to do, but they are in the process of being arranged.
And listening to that and also trawling my own memory, maybe it hasn't taken place and there's one's been missed in the second quarter. So my memory may be flawed on that, but I think that may be the case. And I'm seeing nods from Councillor Van de Ven. Anything else on the action log? And just say it's quite long. And so when Councillor Van de Ven and I have spoken with officers, we've said where something is completed, I know we've been talking about things that haven't, but where it's completed, it should be reported to members, but then come off, because there is a danger that the action log is getting longer and longer. And so we want to see these items resolved. So I will just say that. The action log is therefore noted. Item 4, we've got no petitions or public questions today. Item 5, the first substantive item, recommissioning sexual and reproductive health services with Val Thomas. A couple of points in introduction. It's pages 33 to 82 of the agenda pack. First of all, this is the first meeting where Val has been with us in her role as acting interim director of public health after Jyoti Attry left. I can't thank Val enough for taking on that role. You're doing it brilliantly, but you do brilliant work for us anyway. We know that, but it's great that you've been willing to step up to do that. So we'd like to thank you very much. And of course, as we have said publicly through press release, it's also a time where we've determined to split the public health service from Peterborough, to decouple it in the same way that we did adult social care. and you are very actively involved in managing the transition in relation to that. Thank you very much in relation to that. And I have to say in this report, the fact that Peterborough are not doing prevention on sexual health, and we are, is a very, very good example of why that is going to produce a better service for Cambridgeshire. Val Thomas.
Thank you, Chair, for those words. Thank you very much. This paper is one of our major commissions in public health, and as you can see, there are a number of key recommendations. I'll pick up on the key themes that are contained in those recommendations. Oh, can you hear me?
Again,
Yep.
could you just put the microphone
Yep.
more pointed towards your
Yep,
mouth?
sure.
Would be great. Could everyone sort of please note that? I think we need to get
I'll
the microphone in the end closer when we speak.
Okay. Yes, going back to the recommendations, there's some key points in there, and I'll address each of those points just in summary. The first recommendation is about having a shared service with Cambridge and Peterborough. And obviously, we looked at this quite carefully, given the history, and we now have a set of criteria to assess that direction of travel. The recommendation is that it continues to be shared, and that recommendation is based on the fact that there are financial advantages. Sexual health services are open. That haven't I did listen to your words, Councillor.
Just to clarify, because I think some members may not be clear. So I talked in introduction about the entire service being decoupled. Val Thomas is now explaining that in this particular instance, we're choosing still, in some aspects, to be doing a shared service. So it's not precluding cooperation with Peterborough or anybody else for that matter, where we choose to do it. So I wanted to clarify that in case there was a misunderstanding. Val Thomas.
Thank you. Yes, in the context of decoupling, but there will always be occasions when there are some advantages to remain in continue with a shared service. And the recommendation is that in this situation we should. That's based on a number of reasons. One, financial. Sexual health services are open access, which means that people can access services anywhere. Currently, we have a block contract with Cambridgeshire Community Services, and as the paper says, with context information, that we have increasing sexual health infection rates, and therefore we've seen an increase in activity, and that puts on considerable financial pressure, because then you're subject to tariff, and it's a national tariff, and it would be very difficult to manage those increased costs, because we would be obliged to pay for any Cambridgeshire people that access services in Peterborough. And a lot of them do, because we did review all the patient data and looked at the patient and the patient's access, and basically it's a mixture. People work and travel and go to school, college, and so forth across both areas. The second main reason is around infection risks. It's much easier to spot and to identify for clinicians to identify, the contacts and therefore the potential infection routes for any outbreak or small outbreak, even bigger outbreaks. And it gives this very good overall picture of how sexually transmitted infections are being spread. So, and therefore you can intervene earlier and take the appropriate action. And the third one is workforce. It's a highly specialist workforce in sexual health services, and there's competition for them, particularly senior clinicians, and this enables those clinicians to work across both areas. And without introducing competition, and I think that is quite critical for this service, and it is quite hard to recruit to those types of positions. The second recommendation, key recommendation, is to continue with a Section 75 with Cambridgeshire Community Services. This is based on, we consider them to be a good provider. They perform well. They have been very collaborative. We've done a lot of developmental work with them. They were exceptional during COVID, introducing a lot of new approaches, enabling a lot of online work, which they sustained. And it would be good to build on that developmental work. Another aspect to it is the financial aspect as well. Cambridge Community Service has invested a lot in clinical sites, particularly in Wisbech. They renovated the clinic down in the Limes, down in the south of Cambridge City, and also in Huntingdonshire as well. They also own a lot of the clinic sites across Cambridgeshire. And I think it would be difficult for any new provider to come in and access those sites at an economically competitive rate. There are certain, and it's certainly those lower costs have been passed on to us as well in terms of rental costs and so forth. Also, other examples of where we've worked very collaboratively with CCS, the monkeypox outbreak, they had considerable amount of extra work, but they did not receive any additional resource from ourselves or from anyone, in fact, but they managed that. And it's quite likely in the future that there'll be a vaccination program associated with monkeypox, which again will incur additional work as well. So for those main reasons, we are recommending maintaining the Section 75, which, as you know, is an agreement that can be established between public sector organisations, which does allow a lot of developmental work. And we've had this Section 75 since 21. We set it up during the COVID period, and it has worked quite well between Cambridgeshire Community Services, Cambridgeshire County Council, and Peterborough City Council. The third, that's another critical area, and that's prevention. I think as context to this paper, we provided some information about the increasing sexually transmitted infection rates, both nationally, and that's being played out locally across Cambridgeshire. And really does beg the need for quite a good preventative service as well as a strong treatment service. And at the moment, we currently commissioned the Terence Higgins Trust to provide that prevention service. A few months ago, I met with THT, Chief Executive. They are no longer going to remain in the provider market in terms of prevention services, as it's not financially viable for them. And their concern was the loss of staff, and certainly staff we would value because they've been working in the area for a long time, know the populations they need to work with, and know the high-risk populations very well. And I also talked to colleagues in Norfolk and Milton Keynes who have also commissioned THT, and the route which all areas have adopted, and we reviewed the advantages and disadvantages. They're supporting an integrated prevention and treatment service. The main advantage of that is that our current treatment services has very good links with high-risk population groups and the organisations that work with high-risk population groups. They work well with THT at the moment in terms of identifying any potential risk areas, any potential risk groups, and it's that collaborative approach which is enabled by having more of an integrated approach to prevention and treatment. So you have that continuum of prevention through to treatment. But with the caveat, and I think I would really stress this, at times of stress and increased demand in a treatment service, there's always a risk that prevention will be have less of a focus. And I think that would have to be extremely clear in any service specification and contract, and would be clearly specified that prevention would not be compromised if there were stresses in the treatment services. And sort of in summary, those cover the main recommendations. Obviously, there's a delegation agreements with Peterborough. But I think probably the most important thing at the moment is that we have increasing rates of sexually transmitted infections, and we've seen some small outbreaks, and it's absolutely important that these services are robust and we use the skills and knowledge that we have. It is a mandated services. It is mandated for local authorities to ensure that sexual health treatment services are provided. But I think prevention is obviously key, particularly in the context of this increasing infection rate.
Thank you very much. Let's have the debate. Councillor Van der Ven, please.
Thank you very much, Val. Such a clear paper, and good to note those positive trends nationally, some of the positive trends. Maybe it's an obvious question, but the question of prevention, firstly, I suppose it's important to note the pressures on the Terence Higgins Trust and how unfortunate that is, a sign of the times. But how, and I do very much understand the need for the shared overall service. It makes complete sense. But could you say a little bit more about the dichotomy of the prevention aspect, where we have patient population flows across the county boundary? That's one question. And if I may also ask a second one around the savings from the Healthy Child program, that's in 3.25. I know it's a CYP question, but we have in the past from this committee visited the Healthy Child program when it was struggling after COVID. And I know they've made a lot of progress, but there were some very fundamental concerns. So it's a question around not compromising the Healthy Child program. Thank you.
We'll take all of the contributions and ask you to come back at the end. The next one is Councillor Bowden, please.
Thank you very much indeed, Chair. I have three questions. But first of all, may I add to the comments you made, Chair, to thank Val for stepping up to the position that she has. I have every confidence that she will fulfil that just as well as she's fulfilled everything else that she's done within this council. I'm really pleased with Val stepping up to that position. And it's because I have such confidence in Val that I'm going to be with one tiny exception, maybe, that I'm going to be supporting what we have here today. But I do have some questions. The first one is to do with the financing of this and the amount of money which is being spent. We're talking about in total something, I think it was about £36 million. It is a lot of money. And my concern is that we've had a Section 75 agreement. We've had extensions to that Section 75 agreement so far as we can have them. And now we're having a further agreement here. So there hasn't been a public procurement for some time. And I'm interested to know how officers will manage to ensure that we have correct pricing at the initiation of this new contract. How officers will ensure that through the 5 or 6 year period, there continues to be competitive pricing through that period, and how officers can manage to give members the assurance and the information and the oversight to see that value for money and that pricing information for ourselves, so that we can fulfill our job as this committee to assure ourselves that we are getting this service as economically as we reasonably can. That's my first question, Chair. My second question is on the subject of health inequalities, which is mentioned within the report. And I have absolutely no idea, in terms of health inequalities on sexual health, what the geographical spread is of the services which are provided and the need which is addressed by these services. And I think that it's something that we should know about, whether that be at district level or whether it be at LSOA level. I'm not so concerned, but I think that we should know. I'm hoping that officers do know anyway. I'm hoping the information is available, but I think that we as members should know that, not merely to see as a snapshot where we are at the moment, but to be able to observe what I hope will be a gradual reduction in the inequalities between the various areas which we've got. And that's something I think that we've not really had previously in this service. And I think it would be really useful over the course of the next 5 or 6 years, starting from this beginning position, for us to be able to monitor and to understand what the position is. And I have to admit, despite being on this committee for a significant amount of time, I honestly don't know what differences there are geographically in our county as to the requirement for the services. My final point, Chair, is very much up to your discretion. and that is to do with recommendation B. And I've only just noticed this. I didn't see it when I first read through, so my apologies. We're being asked to agree that Peterborough City Council delegates to Cambridgeshire County Council. We shouldn't be agreeing anything about what Peterborough is doing. May I suggest, with your discretion, that we agree that Cambridgeshire County Council accepts the delegation from Peterborough City Council to do that? That might be more appropriate for us to agree. Thank you, Chair.
Sounds sensible to me, but I'll give Tamar a moment or two to reflect on that, and I'll ask her at the end. Next, we have Councillor Slaughter.
Yes, following on from what Councillor Van Ven was saying, my concern is to do with continuity and overlap and variety, which is such a key thing with sexual health. And that is because we have the Children and Young People's Committee and the Adults and Health Committee both considering this. We have a public health set up now, so ably led, which includes all ages. And in the Cambridge Community Trust, I believe we have an NHS trust, which includes all ages. And I welcome that. I do wonder just how it will work with any separation of services with Peterborough, because I can see the professionals wishing to follow through particular individuals, whether it's through their school career and beyond, or even moving from Cambridge to Peterborough, which I'm afraid with some of the most vulnerable amongst the homeless is a very frequent traffic. And I'm expecting there will be some flexibility there. As Val has managed to explain providers to the chair, perhaps you could quickly tell us whether where the money comes from and whether it is ring-fenced for ages, the money that we receive from various places. Thank you.
Thank you. Councillor Taylor, please.
Thank you, Chair. Yeah, I support the recommendations on this, and I'm quite happy with the Councillor Bowden's suggestion as well. Just let me get my laptop back. I want to pick up on the equality impact assessment when I can find it. So I'm looking at the poverty area of it. So within this area, it's saying limited barriers to access for individuals in areas of deprivation will continue to be important. Online provision is likely to be particularly important for residents of rural areas where lack of car ownership and poor public transport may be barriers to access. It also states that continued provision of the youth outreach clinic in Peterborough to help reduce teenage pregnancies will be important. I totally agree with this, and it's good to see that this has been represented in the impact statement. My only concern is that we haven't included much about Cambridgeshire within the poverty. So it's just wondering whether we can have a look at whether we have continued or any provision for the youth outreach in Peterborough. I just feel like it hasn't picked up a lot on poverty within Cambridgeshire. Thank you.
Thank you. Councillor Seif, please.
Thank you, Chair. Not for the first time, I find myself in agreement with Councillor Bowden on a particular aspect of this matter, and it concerns two things actually. It's an excellent paper, but I was looking at some forecasts so that we can judge value for money. We've got the historic stats, but I have no idea where the trajectory of these numbers would go if we didn't intervene as we are doing. So I would quite like to know if it's possible to say how effective our interventions will be and what the forecast will be by doing what we are proposing to do. I'm not saying that we shouldn't do it. I'm definitely saying we certainly should do it, but it's just a question of what difference are we making? We can see that the the trend has been going up quite significantly. I think it was about 18% over the 4 years that we've been given the forecasts. Oh, sorry, the stats. But I just wonder if we can say a little bit more about where it would otherwise be heading. Thank you.
Yes, please, Councillor Costello.
John, bring it closer. Got it. Yes, I'm a bit concerned about access. Sort of living in Ramsey, which is quite central to Huntingdon and Peterborough, so people could go out either way. Unless, of course, there's 16-year-olds who don't possess a car, and public transport can be quite difficult, in particular trying to reach the site, which is on the Oxmoor estate in Huntingdon, is just really not feasible. I just wondered what outreach work could be undertaken, whereby, you know, staff come out from the Hinchinbrook, the Oxmoor estate, and set up a clinic, you know, one afternoon a week in the Ramsey Health Centre, for instance, which, you know, would enable a lot more people to access the services that we are going to provide. Thank you.
Thank you. My own contribution. Firstly, as a Cambridge City Councillor, the fact that the STI rate is sexually transmitted diseases are highest in Cambridge in the county, above the national average, that new diagnosis is significantly higher, I think needs to be put on record. I don't think this is an issue of blame or criticism, but it's a challenge, isn't it? And so thank you for drawing that to our attention in the report. Like Councillor Bowden, I think there's some percentages in the report on geography, but not numbers that I was able to spot. And I think it would be useful for us to separately receive numbers, because certainly from a Cambridge point of view, it seems to be a particular issue and above where it was pre-COVID. So that's something that I really welcome more action to address. I'd like to welcome the fact that you're presenting this also to Children's and Young People's Committee colleagues, and particularly discussing with them the elements related to children's education and children's sexual health. And I align myself to what Councillor Van der Ven said on that. And it is a good example where we're trying to ensure the two committees work together. So thank you for doing that. Thirdly, let's all be honest with each other. The difficult to reach groups, there's often a stigma about, and then almost a reluctance for us to talk about in public. And so it's really important that we send a message here today as members that we strongly support what our officers are doing in this field. When I read that sex workers and people who should be getting HIV treatment but aren't, are being successfully reached through this, that's great, right? Even though it's difficult to say. And when we see in the report that there's a recognition that we're not reaching sufficiently Gypsy, Roma traveller groups, gay men, homeless people, and that this will enable us to do so more effectively, we should say strongly we welcome that and urge every effort to continue with those intentions. Like Councillor Van der Ven, it is extremely interesting that an organisation as renowned as the Terence Higgins Trust has been forced to withdraw from the delivery of the service. It's not unique to sexual health. It shows pressures that do exist on providers, but it is a loss and I regret it. I do have to say, not that that means I don't have full confidence in the recommendations in terms of the replacement service. I strongly ally myself to the point made by Val Thomas about the need to monitor very, very closely the prevention service and make sure the money doesn't disappear into the health service and then the prevention gets not the priority it needs. I think she's right to talk about the specification, but it's also very important to talk about monitoring. But I say this to other members of the committee. You know, we're not seeing eye to eye with our NHS partners on a number of issues at the moment. And maybe some of that is inevitable, but maybe some of it isn't in truth. And we're teasing that through, and I'm sure it'll bounce back later in the meeting as well. But where someone in the health service is providing a good service and it's the best solution, we're backing it. And that shows that we are bending over backwards to be fair in this. And I share the recommendation here that the best service is one provided by a health service partner in relation to this. Although I hear the question about value for money and I look forward to hearing the answer, but I share the recommendation on that. I'm extremely concerned that the so-called overspend means less hepatitis testing. And if there's a hepatitis outbreak or deaths from hepatitis, that's what we're talking about here if that testing service is reduced too much. And I'm also concerned about capping express testing, which means that people of all ages, young people and people of all ages who need rapid diagnosis, who feel that they may need reproductive health support, might be denied that. And so I strongly support the proposal here to take to Strategy, Resources and Performance Committee the need for the additional £200,000, which I believe will avoid that. And I'm getting nodded. So I think that's really important. I do want to say this finally about why it's sensible to stick with Peterborough on this one. Val's explained this to me in detail, but basically, if you've got a sexual health concern, you live in Cambridgeshire, but you're in Glasgow and go into the local hospital, then we pay for it. It doesn't matter where you are in the country. If you come from Cambridgeshire, they can invoice us and we pay them. That's how this service works. So it's a bit nonsensical for us to say, oh, we're not going to have anything to do with Peterborough on this, when people, for example, in your constituency, Councillor Costello, might choose to go to Peterborough in order to access the service. And so on this occasion, I do think it is the right choice, and shows again we're being pragmatic and in the way that we're applying our policies. Those are my comments, Val Thomas. Oh, can I just say one thing before you speak, Val? Particularly for the new members, we've had a whole discussion in this committee about the proper flow of business. And there's been a concern that if I group together the contributions in this way and people ask questions, that if they feel their question isn't answered, or if the answer prompts some comeback, that there's not a chance to do it. So can I just indicate, please be self-disciplined about how you utilise it. But if, having heard Val, you want to come back for a second time, I am minded to accept that. Val Thomas.
Thank you, Chair. I think the first question was about understanding the patient flows back and forth across the area. One of the nice things about the clinical service is that you can actually get all that information out of the data that you can get from the service. And we looked at all the numbers, and we looked at all their where people live, and could clearly identify where people access services. And then we looked at where we had sort of small outbreaks, and you could see they were very much related to where the outbreak might have been in Cambridgeshire, but in fact it originated in Peterborough and vice versa. So it was that sort of being able to look at data across the whole area gives you some idea about how infections are transmitted, and more importantly, where you can intervene early. So I think that was the infection aspect of it. And it's just that Peterborough and Cambridgeshire, they are so close in so many ways, you know, in where people live, work, socialise, and it is very difficult to split them off in terms of infection control. That was the first part. But the second question was very much around children and young people. No, go on, please.
This question was in terms of the prevention work.
Yeah, that's
okay.
part of the prevention, because you can have that understanding of the prevention needs across the piece. So, for instance, if I give an example, we very often get small outbreaks amongst the homeless population. And so you'd identify a person and you'd say, yes, oh yes, that fits into that category. So then working with the prevention service, they can go and work with that group, get them to get tested and treated. So that's the kind of interrelationship between the prevention and the treatment arm.
Yes, but we have differentiation in funding terms? Because Peterborough is not going to fund this as the prevention work, right?
They are going to put some investment into prevention, but they do it in a different way, because obviously they didn't have the finance to invest in this particular program, but they are using their in-house services to develop their prevention service, and also talking to the North Partnership Board as well, because they've already supported some of their homeless hub where a lot of that work is carried out. So it's, yeah, okay. Moving on quickly, the question about the Healthy Child Programme and the efficiencies that were made, which has obviously been discussed at the SIP committee. This prevention service will focus on adults, and the proposal which was taken to SIP this week was that there would be a prevention service for children and young people, because risk-taking behaviour of young people, it's not split into neat categories, you know, it's looking at children and young people holistically and developing a prevention work around children and young people. And so I could talk more about that, but I can brief you more about it outside of the meeting. In the questions around value for money, which probably of great interest. I think we've done a lot of work in previous years at trying to find efficiencies in sexual health services. They are very well evidenced services, but it's quite difficult in terms of benchmarking them, public health services in different areas, because they are configured in different ways. But we have looked benchmark with services across the east of England, and our cost per one presentation, the first presentation and second presentation, benchmarks below the average. And I think that comes back to things like having lower rental rates, less expensive estates cost, essentially. We've looked at how they've managed activity. We've had an 18% increase in activity, and up until now, we haven't paid them anything extra for that. It's been managed in-house, and they've made efficiencies. And I think what Councillor Howard said about the prevention, the express testing, we could have easily have managed a lot of this cost pressure in-house, but there was that awful risk, I think, and we'd already had feedback. So I think they've done that. We've talked to them now about introducing open book accounting, and I've met with their finance director about it as well, that we will be introducing it, and it will be embedded quite clearly into any new service. And obviously we will monitor that against activity, but also part of that over the course of a Section 75 agreement, we want to see interventions introduced which will be more cost effective, not just the use of more virtual, more digital, because I think we've almost saturated that, and it's been a bit counterproductive in some ways. But I think there are different ways of staffing arrangements, similarly of what's been done in Healthy Child Programme. I think we can learn from that. So I think over the course of the contract, we will carefully monitor activity, benchmarking with external local authority areas, which we have very good links with. But more importantly, I think, is having that granular understanding of how the money is spent as well, because I think that's where I think you really need to ensure you're getting value for money, to ensure that it's being spent on what you're supposed to spend it on. Yep, okay. I don't know, benchmark. Health inequalities. There are just snippets in here of the health needs assessment, which actually does pull out the different health inequalities, both at a geographical area and across different groups. And we could bring it back as a presentation if the committee wishes, which would pull out those inequalities. And I think that probably links to the question on access, because that is certainly brought up in the needs assessment. Yes, it is an issue in rural areas. We have, before COVID, we had sort of outreach clinics in March and areas like that in more rural areas. Our prevention services does provide chlamydia screening to young people, and will continue in the new arrangements as well, but also for adults. But I think it will be a challenge, because it does require additional resources to do more clinics. So it's actually using digital, and I'd be very much interested if the prevention services could do some treatment as well in some of their outreach work. with the new rules around treatment through certain, you can give something like patient group directions, which would allow that. And I think that would help, I think, with some of the health inequalities in a very practical way. And I think the other question was around, when it comes back to the hepatitis testing, it wasn't that it would be less hepatitis testing, it was being put up in other places. So that will be maintained, and it was a cost saving, in fact, for the services. Is that everything? I covered the access, children and young people, the value for money element, and the health inequalities.
Councillor Costello's point about outreach.
Yes, that's the access issue and outreach, which I addressed, saying it is a problem, but I think that it's a combination of using digital where we can and looking at how we can use our prevention services to provide. They already provide access to testing. They give out testing kits, but see if also they could, under the types of directives that are available, if they can also provide treatment in outreach areas. It's a matter of resourcing, doing all the addition to put a fully fledged clinic in different places, given in the context of so much demand.
I think on that point, could that go in the minutes, please, about possibly, I don't know what the right word is, but tweaking the point about the prevention service to pick up the point about access.
Because they are already out working in the community in these areas. So I think one of the developmental objectives would be to use them differently as well.
Okay, I think we're all happy with that. Tamar, I'm minded to accept Councillor Bowden's suggestion about terminological change. Is that all right?
Yeah, so I've just done some rewording. So if I just read out what I've done. So I've said recommendation B, that Cambridgeshire County Council accepts the delegation from Peterborough City Council through a delegation and partnership agreement, the authority to enter into a Section 75 agreement on its behalf with the current provider, and then the rest of the wording. Does that sound acceptable?
Can I, just on that, because we've all just heard it read out, everyone happy? Nod at me if you are. Any objections? And then on the remainder of the recommendations, which I have to read out, apologies, to recommission the integrated sexual and reproductive health treatment services as a shared service across Cambridgeshire and Peterborough. That's A. C, the Section 75 agreement for integrated sexual and reproductive health treatment service with CCS includes the provision of prevention of sexual ill health service for Cambridgeshire County Council only, and this will be provided only for Cambridgeshire County Council residents. And that the Section 75 agreement is £36,112,278 over 6 years with break options at years 4 and 5. And the breakdown is shown in the papers, 22 million for sexual and reproductive health services, nearly 2 million for prevention services, and E, that we delegate responsibility for awarding the contract to the Executive Director for Adults Health and Commissioning in consultation with the Chair and Vice Chair of this committee. Are people happy with those recommendations? I'm seeing nods. Anyone against? No, that's agreed unanimously. Thank you very much by consensus. And thank you very much to Val for that, and I think a very interesting debate. Thank you to all members. We move directly to the Direct Payment Support Service. This is item where the staple is on the sheet 6. Deborah Kakmak, who is Commissioning Manager, joins us to present this report, and we also have Joe Melvin, well known in this committee, Strategic Lead, Adult Social Care Commissioning, who's also joined us at the table. Welcome to Deborah, and to Joe. This is on pages 83 to 104 of the agenda pack. Deborah.
Hold the microphones to them and speak into the microphone.
Okay, so we're hearing once again that some members are finding it difficult to hear. That also means that people watching online find it difficult to hear. So please put the microphone as close to your mouth as you feasibly can. Deborah Kakmak.
Good morning, everyone. Can you hear me? Okay. So I'm here today to present.
You
the
are still a
paper.
bit soft. Just bring it
Okay,
closer to,
bring it
yeah,
down.
don't move your head, move the microphone. Actual device, the actual device, bring it much closer. Okay?
Thank you. So I am here today to present a paper to the committee for the endorsement of recommissioning the direct payment service, which is known as the DPSS for short. As you know from the paper, the current DPSS contract is due to finish 28th of April 2025. Therefore, we are recommending a procurement for a new contract for a 3-year plus 2-year extension option at an annual value of 154,072. And that means that the total contract value will be around 770,360 over the 5-year term. That would start in April the 29th, 2025. So in summary, by having a direct service which will support our service users, this is important because we need to increase the number of people choosing to manage our direct payment in Cambridgeshire. Therefore, the committee is asked to approve the recommendation to recommission the direct payment service. Thank you.
Thank you. Thank you for a very clear and concise presentation. Councillor Van de Ven.
Thank you. I found this paper really interesting, but I would say at the outset, I think the papers that come to this committee are about financial and contract decisions, but they're often pieces of the bigger puzzle. And I'm looking forward to our next big puzzle item on this committee, the big strategy paper that we really need to keep revisiting on shaping the market and shaping the way people receive care and look after themselves. So I guess my main interest here is in how the direct payment service sits alongside the evolution of our our efforts to develop care micro enterprises. And that's part of what we call the Care Together program. But most importantly, the care micro enterprises, which are about setting up small businesses and sole trading activities all around the county. And you can see it in the Care Micro Enterprise directory that we've got online. You can see this phenomenon growing. But my understanding is that the Care Micro Enterprises, which are small businesses, and I believe CQC aligned or regulated, in those cases, council-funded clients may use direct payment to access that service. But where a sole trader has set up an enterprise, it is not possible for a council-funded client to use direct payment. Is that, I don't know if sorry, you can see that I've gone down the rabbit hole trying to understand how direct payment service fits into the broader trend of what we're trying to do differently from the ground up and get to small local providers. And I'll just throw in there that I understand that our home care contract framework, which is not due for renewal for a couple of years, it is a little bit rigid for us right now. So apologies, because I'm bringing up a bigger strategic question, which I think is really important in making sense of why is it important for this council to increase the provision of direct payment opportunity. Does that make sense? Thanks.
It does. And again, please take note of all the questions. I'm sure Joe will be very happy to answer that, and maybe Patrick wants to speak on it. The second one is Councillor Bowden, please.
Thank you, Chair. My question isn't very dissimilar from Councillor Van de Ven's, slightly differently focused, however. I've always been a very strong supporter of direct payments, for ideological reasons as much as anything else, because I believe that patient choice is really, well, patient choice, sorry, it's not health service, service user choice is really important. And I welcome the fact that direct payments do give a much greater amount of choice to those individuals whom we support. And I note that the County Council has also and continues to be a strong proponent of increasing the amount of direct payment. But it's all well and good having an ideological reason for supporting something. What I have completely lacked up till now is any evidence that what I believe in is actually correct. And I would at some point or other, I would really like a dispassionate analysis that direct payments actually do result in better services being experienced by the people whom we are making payments to. Additionally, I don't have any feel at all about the effect on the County Council's finances of going down direct payment routes rather than direct provision of services. And I think that those lacks on my part may be shared by some other members of the committee. Other members of the committee may well know what the position is in both cases. But I think it's really important that we do base our decisions on evidence rather than merely on our personal preferences and our personal ideologies. Thank you, Chair.
I'm a strong proponent of the evidence-based approach myself. Councillor Seif.
Thank you, Chair. Well, I don't disagree with my colleagues on any of the points they've made so far, but my question is a little bit more practical. You give us a timeline of when tenders are going to go out, which is, as I work it out, is next week. But in paragraph 310, we're developing a strategic vision and forward plan, which will include the spec and KPIs and a whole raft of other directions to tenderers. And I don't know where you're going to get the time to produce that before you go out to tender, because I would have thought it would have been included in the tender. And if we've already prepared that vision, should we not be seeing that here?
Tender documents coming to committee, now that would be radical. Councillor Hay.
Thank you, Chair. A couple of things. Within one of the case studies, it mentions SDS. I'd like to know what that actually stands for, because I can't understand it unless I do. But also, what I wanted to know is what exactly does the direct payment support service do? Is it just something where they signpost people to where they can purchase their care? And if so, is it value for money? Also, I'd like to know, with direct payments, is there any restrictions on what that money can be spent on? And is there any checks on how it is spent? And I was a bit concerned to see that tenants in extra care have the opportunity to apply for a direct payment to pay for care and support if they don't wish to use the extra care within that setting. It just seems as if we're paying for things twice, because we're already paying for the services within extra care schemes.
Thank you very much. Councillor Slatter, please.
Thank you. My focus is very much on 3.5 and 3.9 and the stuff that comes in between, because a local case has drawn to my attention a problem we have, and it's illuminated a little bit my own personal experience, which I will mention, and Councillor Hurl is probably well aware of what used to be called Lifespan, which was part of the NHS that did help young adults. And it may not be a very big number, but we look after them for life. And the way in which you look after somebody like that is as holistic as possible. So I used to go along and do the whole business and then come away again. Now, you mentioned in your report that ensuring that a range of services and personal assistance are available to support this ambition is critical. Now, we can help in that through the Care Academy. We need very much to enhance the skills of carers, to include that holistic care, particularly for live-in carers. And at the moment, I'm not sure that I see that our idea of paying for live-in care includes that critical preventative and holistic care that brings well-being and lowers morbidity and, to be frank, saves us money in the long run. Now, it's obviously that uneasy overlap between nursing care and social care, which always gives us problems. We should be improving that with integrated care services. And I would like to see some element, perhaps it is in the tendering, that actually says we won't be paying for a live-in carer who can't do that, because otherwise our residents have to go elsewhere at considerable expense. There is a related element in terms of the micro-enterprises, but those micro-enterprises might well be embodied in the live-in carer with all due safeguards for their competence and their own vulnerability economically. So it isn't an instant answer required, but a case on the go at the moment has shown me that we don't necessarily even insist on a personal visit when we are assessing their financial need or their need for particular sorts of care. And that is crucial. If we cannot just treat it from a financial point of view as a desk study, it does require meeting the person and seeing their environment. Thank you.
Thank you. I next have Councillor Howell, please.
Thank you, Chairman. Just a very quick question, really. Historically, Cambridgeshire has not been as good as surrounding counties with regards to direct payments, with regards to percentages. Now, I don't think this has ever really been nailed down, and maybe too much time has been spent in looking why instead of getting on with improving it. How are we now faring in comparison to other local authorities which are similar to ourselves with regards to direct payments? And what can we do if there is a need to actually increase those direct payments, people who have taken up that particular part of their care? Thank you.
Thank you, Councillor Stone.
What effect do you think an increase in direct payments is going to have on staffing and reorganisation within current staffing? I mean, I noticed that at the end of page 86, several things were itemised: an improved payroll system, additional monitoring, dedicated contact. That suggests that we would need additional staff to make the new system of increased direct payments work well. Maybe you could just comment more on that. Thank you.
My own contribution, 2 points really. One is the officers will answer Councillor Bowden, but I want to put my own thoughts into the debate. I don't think it is just an ideological belief in direct payments. People know I've worked in a number of disability charities. Personally, I know a lot of disabled people. I think probably that's not unique to me, but there are others here who have similar experiences. And people with disabilities themselves have said to me routinely, consistently over time, we want more of this. It's not for everyone. It's not right for everyone, but it's right for some people. And where it's right, it's really empowering and it really works and it really gives people choice. So I agree there's some ideology there, but I can tell you I've got personal experience that this is better for some disabled people. The second thing is I am worried by this report because it doesn't show, and I've spoken with Joe beforehand, but it doesn't show really a self-criticism about our failure to improve this in the past. Councillor Howell is right. You know, for 3 years, we have set the target to increase payments. We're way under the national average, and to give credit to the officers, the figures are in the report. But for 3 years, we've been told by officers we will improve this, and it hasn't happened. And in fact, in the last quarter, if you look at the performance report, it's actually gone down rather than up. And for me, that breaches the transparency that I want to see in this committee and this council, and the honesty about where we're not doing as well as we should be. And we're not in this. And I want, if we're going to agree 6 and 7 year contracts in the future, I want to know that we've learned the lessons where we failed in the past and that we build those into what we do in the future. And reading this report, I don't see that. And so, frankly, I don't have confidence that this is going to work better. Not that I'm going to criticise officers, not that I don't believe that they're genuine in their beliefs that it will be, but they haven't shown us that they've analysed where we failed. And this is a specific target that the council has set. And so I hope in the replies that we'll get pretty full answers on that to give confidence, not just to me, but for all of the committee. Joe.
Thank you. Can everybody hear me okay? Yeah, fabulous. So I think there might be a few of us that answer the questions, if that's okay. Firstly, going to Councillor Van der Ven's point, just to kind of connect where the direct payment support service fits into that wider market shaping. Obviously, through the Care Together programme, we've got real ambitions to transform local home care and to improve the range of care and support available in the community for older people. But in doing so, actually, that is for everybody with care and support needs. The DPSS will play a really pivotal role in helping to connect any of those clients who are looking to have a direct payment and purchase their own care and support in the community. It will help them to find care and support. It will help them to put in place the necessary arrangements. It will help them to pay those providers. It can help them to have a managed bank account. If an individual chooses to employ a personal assistant, and so effectively they become the employer of the care worker, it can help them to understand all of the liabilities and responsibilities they have as an employer. So it's the direct payment service is almost like, in my mind, a bridge to help connect our direct payment clients to the range of provision in the community that is available to them. And what they are able to do is to work with us to help develop that market, help us to understand better where there might be gaps or shortfalls so that we can take that information and use that as part of our broader market shaping. And so as the council has committed to investing in care micro enterprises so that we can offer people a much wider choice of home care in their local community, often more personalised with a carer that they can have a continuing and ongoing relationship with, the direct payment support service will be really important in helping to connect those direct payment clients and say, we can help make it easy for you to employ a CME or to work with a CME. You don't have to just rely on the council arranging home care for you with a traditional home care agency. So in a really broad sense, that's the benefit and the connection that the direct support service will bring. So hopefully I've helped to answer that question. There was a question around having more care and support and the need. We know that our population is growing, is aging. We've looked forward. We have some demand forecasts, so we can see that looking forward, we will need more care and support provision in the community for people. And by doing that, that will help us to manage population growth, but it also offers more choice to people. They can have greater flexibility. And again, some of that, again, that sort of relates back to the principles around the Care Together programme and also our ambitions around increasing uptake of self-directed support. So whilst that won't, the direct support service itself and the recommissioning of it won't solve all of our aspirations, if you like, around direct payments, what it will do is play a really pivotal part of that improved offer to make it easier for people. And the easier we can make it for people, and the more choice that we can offer people, the more likely we can improve our self-directed support uptake. Councillor Bowden, in terms of your question around the evidence that direct payment services lead to better outcomes for individuals, I think is a really, really interesting one. And if we're being honest, one that probably most local authorities would struggle to identify. One of the things we want to do to change that going forward is, as part of the Care Together programme, we are starting to develop a service user experience or service user outcome type measures, where we work much more closely with our service users to understand their experiences of care and their views of the care that they receive. And over time, we'll be able to measure changes in that to hopefully demonstrate that we are improving outcomes and people's satisfaction with the care and support that they receive. So that's an emerging piece of work that's happening at the moment. Also a really valid question around the financial impact of direct payments, because obviously in a way the council has less control over the cost of the care that is purchased where people have direct payments. But broadly, what we know is that when people have a direct payment or a personal budget, they tend to be really considered with that provision and use it in a very tailored way to only have what they really need. And very often what we see is that there is often a clawback at the end of the financial year where people haven't utilised some of their direct payment. Obviously, direct payments are also monitored, and there is an internal team that looks into the monitoring around direct payments, and maybe that Donna wants to talk a little bit more about that. But from a commissioning perspective, one of the pieces of work that we're doing through the direct payment support service, not the direct payment support service, sorry, our self-directed support programme, is to introduce guideline rates for direct payments so that we can ensure everybody's given a fair and equitable amount of money for the type of care that they need. And then it's almost down to the individual to go out and use that budget in a way that's most personalised to them. So that helps to ensure that we can maintain a level of financial oversight in terms of the spend for direct payments. There was a question around the specification and the development of the requirements and the timescales for putting those out. Deborah, you might want to answer that one.
So, Councillor Seif, is it? We did a very comprehensive service review back in April. We looked at the service, we took in all the data and information that we knew about the service from the current provider, and also what we looked at was case studies, KPI data, social value information. So when we looked at that, we did some co-production work with our team in-house as well to see what they thought of the service. So we got feedback from all our operational teams on the current provider and why they thought it worked and why they didn't think it worked well. Similarly, we did that with our practitioners as well. So we came up with a number of really good recommendations. So we didn't just do this on the hoof. What we did is we planned this. We've taken all that into account. We're building the specification around what we want the future service to look like. This is about service redesign. We don't want to go with what we've got now. We want to improve it, as you said quite rightly. And, you know, some of the things that are being done out in the market with other local authorities, we've used some of that information as well. So where we can learn and how we can develop this service better. So it's all been taken into account. So it hasn't kind of been rushed. So although we've kind of brought the paper here today, we are really aware of all of the things that we want to improve on. And I think that picks up on the learning that you mentioned as well. So we have really learned from this. And some of the initiatives that we want to put forward are things like having a really good PA platform. What we don't have at the moment is a good job matching platform for PAs and clients. This will give us an opportunity to go out to market and get that information and requirement. So we're a bit of a loose end at the moment because we don't know how many PAs we have in the market. So this will enable us to have more of that information, and we'll put in some outcomes around that so we can see over time how our PA market will increase. So we'll be able to measure and monitor that in the future, which we can't at the moment. So I think we have a vision. we have a vision for a different service, a better service, and that will be quite clear in the new specification when we go out to market. And I think there was a bit of a, can you?
I was just.
No, I haven't called you, Councillor Slatter. I will do, but I
She
want.
just looked and she saw me say something and I did.
Yeah,
That's fine.
can I ask officers to complete your answers, please?
Okay. We talked about the signposting. What do the service actually do? As apart from just signposting, obviously to other organisations where clients have queries, they all signpost to help, practitioners. They will do training for practitioners. There will be all sorts of benefits. And I think you talked also about the training and development for the care certificate. One of the things that we want the service to do is to manage and have oversight of the care certificate programme for PAs. And because we don't know, again, what the training competencies are like for PAs, on the database that we're proposing, they will be job matched and they will have already had their competencies and training checked and DBS checked as well. So when you see a PA advertising their self-employment and that they're capable to actually offer the service, you'll know that that's already been checked and verified by the provider, so that PA will be able to offer that service with the competencies that we want to see out in the community. So at the moment we have a care certificate, but we don't know what the uptake is. So this will provide that. So there are lots of changes that we're proposing.
Thank you. In terms of the question around SDS, apologies, and acronyms, bad habit, self-directed support, it's a broader term which talks about a range of different ways that people can receive their entitlement or assessed care package, and they are then able to either have something like a direct payment, they could opt for something like an individual service fund, different mechanisms, but it's just a broader sort of umbrella term. I'm hoping we've broadly covered what the DPSS does in terms of its role as being a bridge between people who have a direct payment and the provider market, but also in terms of providing some of those payroll services, and also helping us to maintain and manage our PA market. I think the important thing to note is that there's several improvements we are building into the specifications for this service. We really want this the new service to work with us much more closely in growing our PA market, and helping to retain them in the way that Deborah was talking about. And we want them to have much more of a visible presence and a stronger advice component, both to direct payment clients, but also to our operational social workers. So when they're putting together direct payment levels, they can help to advise on that. And obviously, we want to have much stronger monitoring measures in place for this service as well than we have had previously, to make sure that we achieve the outcomes for both the council and for service users that we're setting out as part of the requirements. I believe that the direct payment percentage uptake is in the performance report later. So I think, Patrick, you're covering that, so I'll leave that on. And then I think there's a question around extra care. I'll just invite Shauna to pick that up, please.
Yes, just checking you can hear me. So we, in the spirit of offering everyone choice and control, we do offer extra care residents the opportunity to take a direct payment should they not wish to use the commission provider within that scheme. I will say that in the vast majority of our schemes, due to the quality of the provider support, delivering support within that service, they're few and far between. However, recognising the value for money impact that you made in relation to this, we maintain really strong oversight of the usage of our hours that we commission within those schemes. So if if our contract management team identify that there are a high level of direct payments, but also a block contract that we're paying for upfront in place, we will look at that information, consider it upfront, and look at how we can manage that to ensure that we continue to achieve value for money at the moment. And it's something that will be covered off in the next report around the Extra Care Improvement Programme by Lisa.
Is there any more from Joe? No. So Patrick, there's 2 points there where you may add. One, how you see this, as Councillor Van der Ven's question, how you see this, right? How you see this fitting into Care Together and the sort of reforms that you're leading. And secondly, you know, I don't question the assessment that's been done. I'm sure it's been done thoroughly and very professionally. So I'm not questioning at all what we've heard. But I'm still not hearing, because I've sat in meetings for 3 years and said, yes, it's not good enough, but we can improve it. And I'm sitting in a meeting now saying, yes, it's not good enough, but we can improve it. Well, you know, unless we're prepared to admit what we've tried and where that hasn't worked, then I don't think we're being honest with people. So could you comment on that, please?
Thank you, Chair. I'll start with that, and then I'll go on to Councillor Van der Ven's question. So the product of direct payments is multifaceted, and I don't think we've got it right in the way that we've dealt with it in Cambridgeshire, and I think that's evidenced by the poor take-up of people using direct payments within the county. Direct payment support service is, however, a vital part of a successful self-directed support program. So opportunity for people to have a greater control over how they live their lives and how they access care and support. But for somebody who decides that they want a direct payment, often younger people usually with a physical disability have a different approach to the way that they receive the money, employ people, and become an employer, and therefore pay taxes and account for that. Whereas other people who access services want some additional support in order to do that, because it's quite an onerous responsibility to say a difference between the council offering a commission service. So in effect, we'll take the organisation and the person delivers the service to them. Whereas somebody who receives a direct payment and then has that responsibility to become an employer and then also oversee the delivery of that service to them and employ people and interview, etc. So the direct payment support service is a complementary service that supports that person in order for them to be an employer and manage their own business. So it's a critical part of our ambition to grow direct payments. However, that is just one part. What we've got to do is we've got to make sure that our social workers and our practice approaches is stronger. So it's much more strength-based, and we're talking to people at a much earlier stage about direct payments being the offer. It's important that we get the messages out there, and a stronger message out there about what direct payments is and how different models work and how people can access direct payments, and make it easy for people to access it and to administer it. And also what we've got to do is make sure our providers are much more flexible and receptive of that. And that includes the small and medium enterprises, the kind of micro enterprises that we talk about within Care Together. And we've also got to make sure that there's sufficient personal assistance out there, so people see it as an opportunity, see it as a career where they can become employed by one person rather than working for a provider and working for different people. So I think there are different elements here. I don't think we've done it well. The self-directed support program that we've had for a number of years within the county, I don't think has worked, because I think it's looked at the wrong end. I think it's looked at direct payments and how do we grow direct payments. What we haven't done is we haven't looked at a way that our practice works and strengthen our practice and our approach to supporting people. And that's where we need to focus on, because what we've got to do is we've got to create an interest, a level of interest and appetite for people to say, that's what I want to do, not go through a full assessment process and at the end say, well, do you want direct payments or do you want a commission service? Because at that point, people often feeling, well, I want this commission service, I don't want all that stresses that having a direct payment works. But that doesn't mean to say that that's not our ambition, that we want to grow direct payments. But I would say in terms of, and I'll get onto the performance report later in the committee, but I think if you compare us to other councils, some councils have gone great. Some councils have got really high numbers of direct payments. But I think if you dig into some of the detail, a direct payment can be, we give somebody £5 and they go and buy a day's worth of daycare, and that's a direct payment. For me, that's not really a direct payment. That's a way of getting your direct payment numbers up. I think we've got to also look at how do we support people to really grow our direct payments so people can have greater control over their lives.
I think one person wanted to come back. Thank you, by the way, which was Councillor Daunton's question hasn't been answered. Just remind us what it was, Councillor Daunton. What's the financial impact? I'll look around the three of you. You know, will it mean less money to Cambridge? I'm paraphrasing it. No. Help me, please, Councillor Daunton.
It was to do with the human resourcing impact. I pointed out a table in the papers. My computer's closed itself down. You're saying that more monitoring and really it was, will you need more staff to make these changes? What will be the human resourcing impact?
So resourcing in the council to support the service extension is, I think, have I got that right? Yes, please.
The proposal that we've got, obviously we're working in a financial envelope that we've got as an existing service fund. We'll be going out to market with that envelope, but also I think because of all the technology and things that have moved on since, you know, with the platforms that are already out there, the cost envelope for staffing could be, you know, as a resource in. Can you hear me? Sorry.
You mentioned something about an envelope. If you could explain exactly what you mean by a resourcing envelope, that would be helpful.
So that's the total value of the contract over the 5 years. So that's the financial envelope that we've inherited that we're going out to procurement with. And then obviously there will be a pricing schedule for the providers to come back on. And there will be, obviously there is a resource from the provider side. I don't think it will be the council that will be, you know, having to employ more staff for this. I feel that there will be enough resource within the envelope.
And just as the words financial envelope are mentioned, Justine Hartley wants in. Councillor Seif, I think, did want to come back.
I do. Thank you very much. Yeah, it's clarification as much as anything else, certainly not criticism. I understand that obviously you've been looking at this service for several months and or longer, you've identified where the deficiencies and improvements are required. I understand that. What I took from what you were telling us is that there's quite a number of areas which you don't have information, and almost you're looking to the market for further advice and information as to how the service can be improved. So I'm having difficulty envisaging what the tender will look like. In other words, what are you specifying, or are you just, is it open-ended? Are we looking for the best idea? We usually are, but how is it being sought? And actually, can you be confident, therefore, that the funding that has been allocated to this will be sufficient? I mean, you know, people are invited to give their best ideas, and it may well be that those best ideas can't be contained within the envelope that has been provided. So it's clarification as much as anything else. Thank you.
Yeah, so I think what Deborah was explaining was that obviously over a number of months there's been a lot of work that's been undertaken, almost like a 360-degree kind of review of the service from all different perspectives. As part of that, we have a lot of informal conversations with both the current provider and also other potential providers in the market. So what we have produced and tried to include in a kind of summary way in the report is all of those proposals that we intend to build into the specifications. When we come to committee to get those approval, particularly where we've got a tight time frame as we have with this procurement, we prepare much of the documents and the requirements are prepared in draft already. And then we use the feedback from committee to incorporate and adjust and sort of refine those documents to make sure. So we are really clear in terms of the requirements that we are putting forward. We're confident that they can be delivered by the market. In fact, we're quite excited about the range of provision that's out there in the market. And we're confident that we can deliver an improved service within the current budget envelope that we've got for this service without incurring any additional cost to the local authority. And to that effect, we are sort of prepared and ready to go fairly quickly, subject to any suggested feedback and committee's approval.
Your KPIs, I mean, one of the things you were saying is that I think 310, that you're going to develop KPIs, but you're telling us they are developed, they're in the tender, and that's what people will be judged against. Okay, thank you.
Thank you very much. Thank you. I think I did get an answer to my question in the end. I've got two responses though. One is, please, officers, in future reports, where we've got shortfalls and lessons to be learned from mistakes, put it in the report. Don't let it have to be dragged out by members of committee. And then secondly, I accept what you say. Actually, I thought it was an answer I could understand. And by the way, I'll repeat again, the evaluation I'm sure was done well. But I'm not sure it's the whole story. And I think I did say in advance, if we can get our machine more aware and more delivering, which is what you're saying at an earlier stage, I completely buy that. And thank you for saying it. But I think the absence of a really strong disability voluntary sector in Cambridgeshire and disabled people themselves supporting each other and acting as peers to really press for this is also a huge difference between Cambridgeshire and other parts of the country. And when Disability Cambridgeshire collapsed, that was a really sorry day for disabled people in our county. And although the disability organisations that we have left are great, and many of them are providing good services, and many of them are our partners, I think that self-advocacy element of disabled people's organisations is missing from Cambridgeshire. And I hope that that feedback will be heard, and perhaps if you're doing some tweaking after the committee, that you will think about putting that in as well. But I think it's been an important debate. I do thank the officers, Deborah, Joe, and yourself, Patrick, for that. And I think the importance of the issue has been reflected in the way we've dealt with it. The recommendations are to agree to the direct payment support service re-procurement due to end 28th of April, a new contract tendered for 3 years, 28th of April next year, I should say. The new contract tendered for 3 years plus 2 extension options over an annual value of £154,000, total contract value £770,000 over 5 years, and B, delegate responsibility for awarding the contract to the Executive Director, Adults and Health and Commissioning, in consultation with myself and the Vice Chair of this committee. Do I see nods for that on both sides of the chamber? Do I see anyone against? I don't, so that's agreed unanimously. We now move, I think we're okay to do another item before the break. So we're going to extra care. And Lisa Sparks is joining us at the table. This is on page 105 to 134. And just as you're settling in, I really like the pathway infographic, which we did ask for, and it's a really helpful way, and I say this to all members, of putting our decision today into the context of other housing type help that we offer and then others offer. So I'm really grateful that that's been done. So this is item 7, page 105 to 134, Lisa Sparks, Senior Commissioning Manager.
Thank you, Chair. Can everyone hear me okay? Oh, that better?
You bring the machine on the table closer to your mouth.
Yeah, is that better? Yeah.
And again, and again. That's
There we
better.
go. Okay, thank you. Right, so good morning, everyone. So we're here to seek approval to retender
Sorry, it's
for.
still not loud enough.
Sorry,
Move
better?
by 2 or 3 inches, the machine on the table, by
Yep.
2 or 3 inches, I'm watching.
Okay.
Better. Okay, go.
So we're here to seek approval to retender 4 extra care schemes at a cost of 5.6 million for a total period of up to 5 years. We're asking committee to approve the spend set out within the paper and delegate authority to award and execute the new contract to the Executive Director of Adults Health and Commissioning in consultation with the Chair and Vice Chair of this committee. Section 1.1 of the paper sets out how the provision of care and support within extra care contributes to the council's ambitions. Extra care housing offers residents the option of self-contained accommodation with access to 24/7 care and support through an on-site care team. Extra care schemes are specifically designed to maximise independence and also include dedicated communal spaces to encourage social opportunities. Extra care helps us to ensure a good range of accommodation options with care and support are available to residents of Cambridgeshire, and the county's demand profiles have identified extra care as a growth area for supporting older adults with medium and lower care needs and helping them remain independent for longer. The table at 2.3 details the 18 extra care schemes currently commissioned by the County Council. The contracts for the services being tendered are due to end in April 2025. Therefore, we're required to re-tender the services to ensure compliance with procurement regulations. The re-tender process has also provided an opportunity to review and update the service specification and take into account feedback from existing residents and lessons learned from previous procurement exercises. Existing residents will also have the opportunity to be part of the tender evaluation with a small group of volunteers evaluating the resident-generated questions, which providers will be asked to respond to. To ensure an appropriate level of cover is available on each site, the council tenders for a block of core hours for each setting, with an option for additional hours to be added when required to meet someone's changing needs or an increased demand for care hours across the setting. The hours and additional hours are shown in the table at 3.1. Both the funding for the core hours and estimated cost of additional hours are included as existing spend within the council's budget. Section 3.3 sets out the details of the 4 schemes to be retendered, and the table at 3.3.6 provides the cost information for you. Building on lessons learned from other recent extra care procurements, officers have put a number of things in place, including ensuring a longer period of time for contract mobilisation to ensure a smooth transition for customers if there is a change of provider, and offering smaller lots to encourage bids from smaller local providers and encourage a more varied marketplace across extra care. To ensure that extra care services are able to deliver the best outcomes for customers, we're also looking at how we can make improvements across a range of areas, including the application process and delivery of greater social value. An extra care improvement project has been put in place to support this work.
Thank you very much. Again, a very clear and concise presentation. Thank you. Who would like to speak? Councillor Bowden first.
Thank you, Chair. I read through this report and I was really pleased with the methodology for the procurement that was laid out here. It was laid out very, very clearly. I do have some specific questions, but I was really pleased with it. One thing which does concern me again, and it was the same with the last agenda item, I'm just concerned that we're not necessarily always starting these procurement processes as far as the committee is concerned early enough. We've only got 9 months before this contract terminates. Same for the previous item. And I just wonder if some consideration could be given. Maybe it is necessary just to bring these forward slightly so that we don't find ourselves right up against it in terms of procurement in case anything goes wrong with the procurement process itself. There were 2 things which I had questions on. The first is the proposal that this contract be put out on a 3+2+2 year basis. And I understand that there's always a tension between providing as much assurance to the potential bidders as you can by having a reasonable period of time that they can be guaranteed for the contract, against the need to ensure that if the service isn't being provided satisfactorily, that we have a break which allows us to terminate the agreement. And my question is 3 + 2 + 2, particularly the initial 3, is that sufficiently encouraging to potential new entrants to the market? And I was so delighted to see in this report about the encouragement of having new entrants and of splitting the overall extra care provision that we have between a number of providers. I thought that principle was really important and really welcome. The second question I've got is also to do with the procurement, stating that the assessment will take place on the basis of 70% quality and 30% price. And I looked at that and smiled to myself. And the reason I smiled to myself is that before this administration, I was the vice chairman of the old health committee. And I did an exercise on one particular procurement, which was meant to be 60% quality, 40% price. And I did a mathematical assessment, and I'll talk a little bit more about that in a second. And when I did that, I was able to show to the then leader of the council that, in fact, it had been the contract had been allocated on the basis of 97% quality and 3% price, because the methodology for the calculation was different between price and quality. Now, in that case, fortunately, the bidder who had the best quality also had the best price. So there was no doubt that the correct decision had been made. But on a mathematical basis, the problem that we can have is that when we are looking at quality, we tend, not always, but in many cases, we tend to utilize blocks by assigning a number 1 to 5 for various criteria. And so it's an iterative process, and there is an incremental level between the cumulative number of points which are assigned to each bidder. Whereas on the financial side, on the cost side, it tends to be a mathematical process which is based very often on the cheapest price, and then a mathematical formula is applied, which isn't incremental. Now, what I would ask, Chair, and it's entirely to your discretion, is in this particular case, and this isn't, I'm not getting at this particular process, but sometimes it's useful to challenge. In this particular process, would it be possible at an early stage, well before we're actually talking about bids coming in, would it be possible for the methodology of the calculation of the cost and of the quality elements, could that methodology come back to you and be shared in spokes so that we can make comment on that? Thank you, Chair.
That was put extremely clearly. I understood it. And actually, I think your request, which is that we have an item on spokes on this, we can just agree. And I'm looking at Patrick, and the answer is yes. So I think the point goes on the record, but we don't need to discuss it further. And I congratulate you on your clarity. I promise you we are having a comfort break after we finish this, but I'm going to have to leave the room quickly myself. So Councillor Van der Ven will take over and Councillor Daunton will be the next speaker. I'll be back shortly.
It's actually quite a small detailed point, but in general, throughout the paper, it's clear that there are a range of providers, range of different buildings, sites, and different providers. But there's one paragraph which seems to apply to all of them, and that's 2.5. And I'm really puzzled because it says that the on-site care and support services are available 24 hours a day, 7 days a week. But in addition to this, all residents are required to pay £16.90 per flat per week to ensure that there's capacity to respond to emergency pull calls. Seems quite a significant amount of extra money, given that there is already 24-hour care, and that's included in the general payments.
Thank you, Claire. I'll move to the next question. Councillor Black.
Thanks very much, Chair. Just to go back to Councillor Bowden's point, my concern on some of these things was that I got the feeling that although we were giving higher percentages to quality, that the bidders were sort of tailoring what they're putting in for the quality, and actually what was distinguishing them all the time still seemed to be cost. And that the quality really depends on the number of staff they actually have and how much they can make that permanent, not agency staff, and that businesses that were not going to do very well on that could not be distinguished from those that were going to retain. And the cost of not paying people so much, for instance, was going through on the cost and probably not being seen on the quality. So, I mean, that is my concern about the whole way these things are going. The reason what I really wanted to talk about on this issue was Appendix C, because as a joint authority, we have been looking at wanting to insource things in social care, and I'm not sure if this is the one that I put absolutely at the top of the agenda, but looking at Appendix C, I don't feel that our aspiration to insource social care is really being taken seriously. And looking at the template and some of the answers to it, it concerns me. I mean, if we look, for instance, at item 12, what are the risks if the in-house arrangement fails to deliver? It says, well, their outsourcing would be challenging due to 2P implications. Well, the constant procurement and sort of chopping and changing brings 2P problems every time, whether it's a private sector company replacing another private sector company. It means you get this vast range of people on different conditions. And it talks about the potential of leaving somewhere unstaffed. Well, we've actually got that on our privatised arrangements. We've had domiciliary care companies and a major national homes company let us down and leave places unstaffed and leave us scrambling to try and do the provision. I don't think we're going to let ourselves down in that way. It seems strange that this is used as an argument against insourcing. If we look at item 4, it talks about the additional costs for insourced staff, and at item 8, I think it says the greater cost of Cambridgeshire County Council staff, for instance, pension contributions. But precisely what is wrong with private sector involvement is that they force down the terms and conditions of staff. We're saying that it's a problem that we insource something and people have higher pay and proper arrangements like decent pensions. And actually, that's been advocated against insourcing, when the great advantage of insourcing is that people are treated with respect and that workers get fair conditions. And the crisis we have in social care is very much caused by the constant driving down of people's terms and conditions. Number 8 on this thing, it talks about the cost of the additional staffing costs of training an agency, as if that's a problem of insourcing. That is precisely what we have with outsourcing. And Radis Limited run Reading Supported Living. Their most recent care quality results were from June 23. They needed improvement on everything: safe, effective, caring, responsive, well-led. And in the end of it, all of it came down to the fact that they did not have enough permanent staff, that they're constantly using agency staff who were not up to the job. And what is missing from our thoughts of insourcing, the whole point of insourcing is that if you're outsourcing, lots of the money our council is spending is going out in private profit. So, for instance, Radis has a 24.8% gross profit margin on a £50 million turnover. Their earnings before interest and tax are a good deal lower. I mean, they're also expanding very, very fast. Their directors get £100,000 each a year, but I mean, I think a lot of what their value is the exponential increase in the value of the company. We should be evaluating what is likely to go out in profit. And, you know, if you say, look at somewhere and there's a 10% profit margin going to the private sector, how could we spend that money to improve the respect and the decent treatment of the workers and to give a better service to our service users? I'll conclude by saying I do agree with some of the things in this report. I welcome the way we've addressed problems we've identified in the past and split it into lots, that we're talking about not letting one provider have a monopoly of it, so that we are market shaping, and that we're saying that we will look at insourcing as a more wide sector element and looking at extra care as a whole as well. But what I'd like to point in record is I think I want to see much more work done on the benefits of insourcing. And I want to see the evidence that this council is looking at the policy that we have and actually will be getting through to giving our service users a better deal, and also quite possibly saving the money by eliminating some of the private profit that is coming out of social care. Thank you.
Thanks. Again, that's a wider point. I might ask at the end, Patrick, to comment on it. But thank you for your contribution. The next one, delayed. Sorry, Councillor Van der Ven, is yourself.
Thanks. Just, I guess at the start, I would always want to say that extra care is another name for independent living, I believe. And just as a point of interest, we have so many extra care provisions around the county. It'd be interesting to know what proportion of independent living that makes up. At some point, be useful to understand that. Following on actually from Councillor Black, I was going to ask a question, follow up what was said in the previous item about direct payment. And I know, Shona, you mentioned that typically direct payment wouldn't be an appropriate setup or isn't so commonly used in extra care. I would say well, I think it kind of relates to what Councillor Black was saying. I believe we have a responsibility and an obligation when new clients come into extra care to make them aware of the direct payment option. And in fact, if we are, I'm going to go back to the care microenterprises and the self-employment, and Councillor Black, you've been talking more broadly, I think, about private providers, but we are encouraging new local small business. They may be private, but they are small and local. And this is another kind of choice, I think, that we need to really promote in the extra care setting, if I understand correctly, that is an option. The other point I wanted to make relates to what Councillor Daunton said about the pull cord. I think this is called the peace of mind payment. It isn't said in this paper, but it is, I believe, this is called the peace of mind payment, which in my own experience, my own division, residents in extra care were unaware of. Just looking for the paper. I think it says that this is under review, and I think it's really, really important that we have a chance to debate this. It's a lot of money. And when 24-hour care is available, what's the sense of it? So I would like to get under the detail of that. Thank you.
Thank you. Councillor Taylor.
Thank you, Chair. Yeah, I support this paper. The only thing that I want to touch on is the procurement side of it. This item and the previous item, I've noticed that you're continuously going out to tender, and do you ever consider frameworks for the procurement? I'm no expert in this, but I know that in children's and young people's, we use frameworks a lot. So this is where you have your providers, you vetted them, they're all in a little pot, so to speak, and they're ready to go when you need them, when these come up, and then you're not scrabbling around for time. It saves the lengthy process in the tender of these providers. So I was just wondering if it's something that we've considered in these areas, or is it because there is a criteria in the procurement framework that is preventing this on these type of tenders? Thank you.
Thank you very much. My own comments. One is I agree entirely with Councillor Bowden on the timetable, and he and Councillor Sleeth and myself have all said we're getting these reports far too late to really affect the contracting process. I know there's some sympathy amongst that in the officers. One of the monitoring officer or democratic services or both says that we're not allowed open committee to have a strategic report looking at the future timetable for commissioning and giving us a chance to have early comment. I completely disagree with that. Put that on record. We have seen one attempt at doing that report in Spokes, which I acknowledge, but I think that should be for all members of the committee, not just for Spokes, and I hope that will change. On insourcing, I'll let Patrick answer the points raised by Councillor Black. But what I would say is I found this is the first time that questionnaire has found its way onto a committee agenda. Insourcing is in the Joint Administration Agreement and the strategic objectives agreed by the Council at Strategic Resources and Policy Committee. So wording that's sent to officers that says the Joint Administration has shown an interest is completely inconsistent with the policies of this Council. And I might ask for it one day, but I would like to see all of these forms and to see if they just say the same thing over and over and over again, in which case the system is clearly not working. I have great sympathy with what Councillor Black said, although I think there is a bit of an answer to it, but I'll let Patrick give that. And finally, can I just say, Councillor Van de Ven referred to it, but also Shauna Torrance in your earlier comment, I think that we're offering direct payments to people in extra care does make it more complicated for us and even possibly a bit more expensive, but it's giving people choice. So I'm really grateful that you built this in, because we should create more problems for ourselves and less problems for our service users. So good for you for doing it, and I completely support it. First, I'll ask Lisa.
Thank you, Chair. So the question with regards to whether the 3+2 term of the contract encourages new entrants, the last few extra care tenders we've done, we've had well over 20 plus bidders. And when we've done market testing and we've asked the providers around what their ideal length of contract is, those are the sorts of numbers that are coming back, a sort of 3+2. So we've kind of taken that as a sign from the market, if you like, that we're pitching it at the right level. I noted the comments on the quality and price split, and obviously that's something that we can take to Spokes, so I'm assuming that we can cover that one. The range of providers and sites and buildings with regards to the peace of mind charge, I think Patrick would like to pick up that comment. Are you okay for me to hand that over to you now?
Do you want to complete?
Yeah, no, that's fine. Absolutely.
Can pick up,
There was also a mention of bidders being able to tailor quality and it coming down to cost. From the evaluation process, I can confirm we do have a range of quality scores. So people are putting in very different responses to the questions and they are being scored very differently. So I don't think we have a situation where everyone kind of knows the exam question and everyone feels they can answer it very easily. So it's still a challenge for those bids coming in, which is rightly so. In terms of the question, Councillor Van de Ven, regarding CMEs, we're actually liaising at the moment with Care Together to try and encourage more interlinking between CME agencies and extra care services, with that option of kind of introducing one to the other so that people are aware that it's an option out there, that even if it can't necessarily meet their assessed care needs, there might be something else that those services can provide for them. And in terms of the frameworks, we have considered this previously, using a framework for extra care. We had previously looked at this as we were moving to a different delivery model for home care. This is something we'll also pick up within the extra care improvement programme that I referred to. So part of that will be looking at just how we procure our extra care services at the moment and exploring other options for the to the current arrangement around blocks and individual contracts. So that will all get picked up within that wider piece of work.
And Patrick, please.
Thank you, Chair. So on the peace of mind, yeah, that is so this is a contract. The paper here is about contract for care and support, which is built into a block arrangement within each of the schemes. The peace of mind is a universal service that's available to all tenants, residents within the accommodation. So not somebody who's had an assessment under the Care Act, but this is available to everybody. We are under review because there's been a local government ombudsman recommendation that we need to look at it for consistency of application. And so there's a piece of work which is reviewing the peace of mind charge, not just for these schemes, but for all of the extra care schemes and any future extra care schemes that we have. So just on the in-house and the insourcing, so it is a factor that we consider on all our decisions. The template here has been shared because we've heard from committee that you want to see the evidence that we've done it. I think we've heard from Councillor Black, particularly around the comments that we need to think more around the evidence that we gather when we're completing these templates to justify some of the scrutiny and the due diligence that we're taking. But we do consider that against the other costs of not bringing it in-house and the opportunities that does or doesn't bring for us. So we continue to use this template and apply that against all of our contracts that we outsource or our tendering.
With the red quadrant work, I thought you'd probably comment on.
So we've commissioned a piece of work that's looking at our in-house services. It's looking at the opportunities for our in-house services has to both increase its efficiencies or expand its opportunity and its range of products that it could offer. We actually have quite a few in-house services, probably more than other councils, but there are still other services that we don't operate. So there would be some cost if we were to bring services in-house. So we need to consider that and how ready we are and how skilled we are for our current arrangements to bring other services in. That's a piece of work that's underway at the moment, and we await their kind of interim and final report for the recommendations and areas that we need to look at on that particular piece of work.
Thank you for that. Just to be very clear to Councillor Black, my expectation, and I've met with the consultants, is it will look at future contracts over the next years and identify which ones are the right ones and come up with a shopping list of ones that we can target for insourcing. That's my expectation. That's what has been said to them, and that's the assurance I've been given by officers, and Patrick's nodding. So let's be very clear about that. Okay, one other question. Thank you, by the way, for the answer. One other question perhaps not answered or response, Councillor Slatter?
Yes, it's again related to insourcing, and as Liz Sparks is well aware, I am very keen to do more than get in at the beginning, but actually make the beginning, and to actually be considering where we can build new lifetime home supported housing, perhaps in partnership with private provision in the same area. We know where we've got growing communities, and those are well, I can't be the only person that's lost supported housing and gained older people who are going to need it. So it's not just a plea for Trumpington, but I want to know that we are going to be able to get in plans for that. It seems that this committee is very reactive. I'm not sure where we do the planning. I'm pretty sure it comes in through assets, and we know we're having a review. So I'm going to exploit the opportunity of this committee, I'm afraid, to say I've got my eye on Fawcett House, as you know, but there are so many good reasons to be talking about it well in advance so we don't miss opportunities. Thank you.
Okay, I'm not going to ask officers to come back on that, but I will ask for it to be minuted, not about Fawcett House in particular, but I do know that Patrick is intending to bring back a report to us on housing strategy and is reflecting in detail on this. So that report will come, and that will be our opportunity to look at that. Okay, we've got thank you to the officers again. The recommendations are A, to retender for 4 extra care schemes, total value £813,000, 5.6 million for the contract period of 3 + 2 + 2 years, extensions at the council's discretion. with the ability to vary and give notice throughout the lifetime of the contract. Don't read that normally. And adjusted for future inflationary uplifts, and B, delegate authority to award and execute the new extra care contracts starting 26th of April 2025 and subsequent extension periods to our executive director in consultation with myself and the vice chair. Am I seeing nods? I am. Anyone against? Agreed unanimously. We will now have a 10-minute comfort break. So at 12:20, please, promptly, please be back in your seat. 12:20. Right, thank you very much. Yes, it's exactly 20 past, so we can go ahead. Item 8 is adult social care debt update. That's pages 135 to 142 of the agenda pack. Welcome to Richard Gibson, Head of Finance Operations, as well as Justine Hartley, our Strategic Finance Manager. I invite them to address the committee.
Thank you, Chair. Is this okay for sound? Excellent, thank you. Right, good afternoon. So this report provides the Adults and Health Committee with an update on the debt position in relation to adult social care services and the actions being taken to improve this position. It also provides an overview of the financial assessment process that establishes the means-tested charge for care and support, along with information on how adult social care charging links to debt and the support offered where individuals face difficulty in paying these charges. So the collection of income due to the council is a shared responsibility between the service area to which the income relates, adult social care, and the corporate debt team. For the committee, most invoiced income relates to contributions towards the cost of care, be that from health partners or from individuals who are assessed as able to contribute to the cost of their care. Strategy, Resources and Performance Committee is responsible for the overall strategy in relation to debt collection. Audit and Accounts Committee.
Richard, sorry to interrupt
Sorry,
you, but
yes.
you're just reading from the report and we're well behind, not your fault, fine.
Absolutely.
So apologies, but would you mind summarising the key arguments rather than reading from the report?
Certainly, so certainly, Chair. I think the key elements within the report are, although with an increasing debt position over the course of time of the last 3 years, the report sets out some of the root causes of that rise in debt. So some being attributed to increased billing over time, others being challenges more nationally with things like court protection, Office of the Public Guardian. The report also sets out in section 4 the actions that the functions and services are taking to address those debt positions. The report in section 3 sets out the actions the functions taking to support people in their cost of living and anti-poverty. So where clients and citizens have challenges with their contributions, we offer them as many ways of supporting them in paying their contributions as possible. For the interest of time, should we go to questions?
Very good, and I trust all members have read it, but I thank you for giving that summary introduction and indeed for providing us with the report. Councillor Bowden.
Thank you, Chair. My apologies. Thank you, Chair. Before I ask my question, may I just ask for a point of clarification on the report? It's in paragraph 3.2.1. And in that paragraph, we're told about NHS overdue debt. And we are then also told about overdue integrated care board debt. Is the overdue integrated care board debt part of the NHS overdue debt?
Yes, absolutely.
Good, thank you. It wasn't 100% clear from the report that that was the case. I assumed it was. Looking at this report, and you know, Chair, that I've often commented on the debt position. I really was quite shocked by seeing the amount of increase of NHS overdue debt, and some comment is made here about it. I fully accept that there are a whole host of reasons, some of which are national reasons why debt overall has increased, and some of them are particularly problematic, like the probate issue, which are absolutely outside our control. But when I looked at paragraph 3.2.1 and saw that, and again, we're just comparing two dates here, but the NHS overdue debt relating to adult social care had increased from 1.4 million at the end of March 23 to 13 million at March 24. That is more than 9 times as much debt in that 1 year period. It really did concern me. And Chair, you know as well as I do that there is a code in some of these reports when they're written. And when I read the phrase, the council is very actively engaging with the ICB to secure payment of these sums, I read that as meaning that we're having quite a furious but professional argument with them about it. And it really isn't acceptable, to be quite honest, that cash flow should be affected this way between organizations which are meant to be partners. Now, I'm not going to risk crossing your red line, Chair, by saying again what I think about previous health acts and where we are now. So I'm not going to cross that red line, but we've got to do better than this in terms of working with our partners to ensure that there's a correct flow of money where it's appropriate to have that flow. And that clearly isn't happening. It's being signposted here, but I'm not sure how we achieve this. And I would have hoped that goodwill between partners should solve this problem. And if goodwill isn't solving it, I'm not quite sure where we go from there. But it's a highly unsatisfactory position for us to be in, Chair.
And thank you for that. By the way, Councillor Van de Ven next.
Thank you. I just wanted to say thank you for the paper. I found it incredibly comprehensive and helpful, and particularly in anticipation of the charging review work that we're going to be asked to look at. So I felt this was very, very good preparation. And also, I just wanted to note that the paper reflects a really terrible condition of life that so many people face, and that's maybe assumed, but it's just jumps out in this paper, and I wanted to acknowledge it. And that's all. Thank you.
Thank you, Councillor Seif.
It is working. Yeah, apologies for missing the first part of the presentation. And if somebody's asked this question already, I apologize. But I thought when we discussed a similar paper, possibly a year ago, that we were going to be receiving an aged debt analysis with categorized by obviously things like protection, which is a special category, and all the other categories. And I just wonder what you thought would be the normal level of debt, what it should be. We seem to, I'm going to give a figure here, we should be receiving about 70, 80 million pounds a year. So if we collect within a month, that should be probably 6 or 7 million. What do you think would be normal? Clearly, we got some exceptional debt here from our partners, but I just wondered whether what we should be expecting, basically. Sorry, hesitant there.
Any more members? My contribution. Firstly, I'm really grateful we've got this on the agenda. Patrick will smile, but there's been a huge lot of coming and going about committee terms of reference since last December to enable us to get it on the agenda for today, which all of us would have had vastly more time in our lives if we hadn't had to take part in. And I genuinely think it was Graham Wilson that first asked for this to be here. And although this is a Strategy, Resources and Policy Committee joint responsibility, it's clearly interesting for us to see what's going on and to be able to comment, at the very least, to our colleagues on that committee. And when 60% of debt of the authority we're responsible for in our services, for us not to be able to see that and to talk about it is absurd. So I'm grateful that common sense won out. And as I sometimes moan, it's also important to say thank you where we've managed to crack heads together and do the right thing. Secondly, clearly what we're trying to do in this report is to inform ourselves better about balancing being better at revenue collection whilst being sensitive on anti-poverty considerations and making sure we're getting the balance right. I think this report does help me to be better informed, so I want to pay due credit about that. And I think laying it out in writing about the disability-related expenditure waiver and the help we give on welfare benefits, for example, I think it's very helpful to put that on the record. I'm not going to ask for this report to come back, but it would have been more helpful to also see how those numbers were doing compared with other authorities, because I couldn't really tell that the £1 million, for example, on welfare benefits was good or bad in terms of the overall, but perhaps that could just be given to me personally outside the meeting. But I think it's important when we do the charges review, as Councillor Van der Ven says, that we do look carefully at good practice in other authorities. And I know that is the intention for us to do that. I did ask that our anti-poverty lead from communities be a co-author, and that didn't happen, and I regret that. And I do ask for that to happen in the charges review. I think we've got expertise in the authority on anti-poverty. We should be using it. And, you know, part of my interest in this report was that although we all want a better financial position for the authority, you know, I get emails and letters from people who are the relatives of deceased people who are being chased for debt. And the language and the way that we approach it hasn't been as good as it should be. And, you know, I think we have to be open to that criticism. I don't really see that evaluated in this report at all. And, you know, I think it's too soon to come before the council, but we've received an ombudsperson's report against us in relation to chasing the debt of a deceased person. And if you are the son or daughter of that person, how we talk to them is really important. And it's no good us saying we're great on direct payments and co-production and all the rest of it, and then not to show that same attention and sympathy and sensitivity in the way that we deal with our debt. But I do think this is a step towards that. I do. And I hope when we get the charges review that we can do that in even greater detail, and we can be given even greater confidence. And I am grateful to officers for bringing forward this report. Someone's come in as well as I was speaking, Councillor Taylor.
Thank you, Chair. You've just hit a thought in my head with chasing debt through residents that have deceased and their family. What I would like to know is, do we have a bereavement policy that we follow? Because that is very important. I've recently gone through a death in my family and have found that many organisations are very good at responding to you, where there are some that aren't, and they just do not have any kind of policy in place to do with bereavement. And I think that's something that we should have and something that we should follow.
Sure, officers will pick that up. Maybe not Richard, but it may be one of the other officers here. I was hoping Donna might come in with the last contribution to committee, so that may be her chance, but we'll see. Richard, please.
If it's okay, Chair, I'm just going to take the first couple of questions.
So Justine Hartley, I have to introduce you, Justine Hartley.
Okay, thank you. First of all, I wanted to come back to Councillor Bowden just on that ICB issue where we talked about actively managing that. And it was two elements that were key there, ISIS and learning disability. So the ISIS one, we have got agreement to, that's all going to be paid now. So it's just the learning disability that is still under discussion. Councillor Seif, in terms of an age debt analysis, I was just trying to look back at last time's report because I think there is an age debt analysis that goes to Audit and Accounts Committee, and every time it goes to Audit and Accounts Committee, I've committed to replicate it into the report that comes to this committee. There hasn't been another report to Audit and Accounts Committee since the last one, but when they do take the next one, so the next FMR report that I bring to the next committee, I will replicate what's in that so that you see that here. In terms of the level of debt we should be reporting, so as the value of client contributions goes up, obviously you expect the value of debt to go up if everything else stays exactly as it is. What we've been working to try to do is to think about where we expect the debt to kind of turn a corner and start to come back down, because we acknowledge that it's higher than we would want it to be. In terms of that, really looking forwards, I mean, even to stand still and keep the level at the level it is now is an achievement against that sort of rising level of debt. So I think that's where we think realistically from the actions that we are taking as part of the debt deep dive, we can get to by the end of this year. And then we want to start seeing it come back down. But a lot of the things that we're doing are quite slow to turn around. So changes in processes and things, and some of the court of protection and the deceased things do take a long time to sort through. So we have got more old debt than we would like, but a lot of it is tied up in those processes, which can take a long time to resolve. So It's not a quick win, it's a longer journey, but it's certainly a very active programme to try to turn that debt curve around and bring it down. Thank you, Chair.
I think Justine's answered Councillor Sif's questions as far as we're able. And I don't believe there were any further questions.
Okay, I don't know whether it's Donna or Patrick or someone else, but bereavement policy that Councillor Taylor, well, what do we do to help? We are going to have Donna for one last time. Great.
Thank you. So we don't have a bereavement policy as such. Our social work teams are constantly engaging with people who've experienced or are preparing for loss. But you've sort of picked up on something that's quite current in our conversations. So I've recently had some interactions with our corporate debt team around some of the finer tuning and some of the language that we use. So when we go out to collect what we're calling debt from families who've recently experienced a bereavement, for example, even that terminology can be quite alarming if you're sort of picking that up and coming into contact with it for the first time. So I was just checking my emails, and the last time we exchanged an email on the topic around the subtleties of that wording was on the 7th of June. So we're trying to think very hard around some of that softer communication, etc., which it's not incorrect, but actually how it lands with someone who's just experienced bereavement is something we want to consider further. So we're not there yet, but it's work in progress.
Councillor Taylor.
Thank you, Chair, and that's really good to know. I think when there is a bereavement in the family, and if the estate goes to probate, there is absolutely nothing that family can do. If they've got bills to pay, the estate is frozen, and there is nothing they can do. So when they are getting debt letters coming in, they're stuck. They're absolutely stuck. So we have to be really, really sensitive on cases like that. Thank you.
Okay, I think that speaks for itself. The recommendation here is simply to note the report. Are people happy with that? I'm seeing nods from all around the table. Anyone against? No, that is unanimously agreed. Thank you to Richard, Justine, staying with us, because our next item is item 10, Finance Monitoring Report for May. It's pretty early in the year, folks, but it's still there. Pages 187 to 214 of your agenda pack, and Justine Hartley will present, please.
Sorry,
Ooh,
so
I've made a mistake.
I think I'm doing
Right?
the year-end report first.
I've been reading different reports and I've confused myself. I do apologise. This is the March report, which is, of course, rather interesting as far as the previous year is concerned. Justine.
Interesting. Thank you. Thank you. Okay, so I'm not going to say very much because I'm sure you've all read it. We've talked about the numbers lots of times and I'm very aware of time. But just the end of year report. So adults health and commissioning ended 3.8 million underspent. That sounds like a big number, but it's only 1.8% of budget. And there were lots of things behind that, lots of overspends on some of the care costs, particularly around LD and mental health, but some underspends elsewhere. But overall 3.8 million under, and for public health 126,000 under. Just to say on that public health balance, obviously that the process that happens in the council is that gets transferred into the public health reserves at year end. And we are doing some work now looking across the public health reserves, a bit of a refresh, not so that we can come back and bring proposals around anything that what we might do with that 126 and anything that might need to change on any of the other lines to committee in the future. So just to note that. That's about all I was going to say on the end of year report. You have also got the savings tracker in there and the earmarked reserves, obviously, but yes, happy to take any questions.
Thank you very much. Councillor Sif.
Thank you, Chair. As an accountant of sorts, which I often hate to admit, I'm in admiration of the, I'm looking at page 166, which is in effect the detailed analysis of the year's income and spend, and to get within 1%, or sorry, under 2% of a £215 million net budget is quite an achievement, really. It's quite remarkable. But I look at the figures, and each individual budget is all over the shop. There's some up and some down. And I don't know how worrying that is in itself, but what I really would like to know, and it may be very difficult to explain in a meeting like this, is whether and how the budgetary control system works. So I can see Councillor Bowden is laughing. Because are you tracking on an almost day-to-day basis where you've got an overspend? Because many of these things you can't control. I mean, obviously you don't know how many dementia cases, which I think was one of the bigger overspends. I may be wrong there, but I'll have a look in a minute. You don't know where these costs are going to come, but nevertheless, you've got to deal with them. And so you spend above budget on that, and you've now got to cut your budget to come back in on some of the other items. So just in brief, could I ask, how does it work on a sort of day-to-day basis? Are you able to say, no, we've now got to cut back on budget A or budget B because we've overspent on budget C? I don't know if that's a silly question. But
Also part of the accountants party in our council, Councillor Bowden.
Thank you very much indeed. And I am going to unfortunately also speak on a fairly technical matter, but it's one you've heard before. And it's not surprising because we've been given plenty of warning by officers over the last 15 months that we have an underspend within public health. And that's not unexpected. It might be slightly unexpected that it's as small as 126,000, but nevertheless, we knew that was going to take place. And I welcome the fact that now we're going to look at ways in which it may be possible to spend that 126,000. But once again, we're talking here about the Public Health Reserve, and we are being far too reactive in terms of how we plan to spend the Public Health Reserve, because we've had, let's take this as an example. Last year, we had 126,000 we didn't spend, which we could, and it could be argued should have spent on public health. And then when we make a decision about how we spend that money, given the nature of public health, it may well be that it's spent over 1 or 2 financial years. So we have this continued drift between the period when we received the grant for public health and the period when we spend it, given the underspends which exist in the Public Health Reserve. And I know, Chair, that you share with me the importance of preventative public health measures which are taken. And I would just ask, I'd ask Val in particular in her new interim role with you, Chair, if consideration could be given, instead of us being reactive on the Public Health Reserve, for us to be proactive on the Public Health Reserve and thereby get a one-off increase in spend, which might go over the course of 2 financial years, over and above what we otherwise would have had, so that we catch up, so that on average, we actually spend the amount of money on public health that we actually receive. Thank you, Chair.
Hang on, just to clarify things. I'm going to, after the members are finished, and I will bring you back in, I'll get Justine to answer first, but I will give Val and Patrick a chance to come back in because I think some of the issues they may want to comment on. 60 seconds, please, but I will allow you to come in for a second time.
So actually, I forgot to ask the main question that I was going to ask. I got so carried away with budgetary control. Page 170, I noticed that we've made a contribution of 1.161k to the council's bad debt provision. Is that a general provision? And what's it doing in this account, if it is? Because that's really not the way to report it, I suspect. If it's to do with bad debts specifically for social services, whatever that particular, it's the item 1, isn't it? Adult health and commissioning. Then that's a different matter.
And you did it in less than 60 seconds. Thank you. My own contribution. I like Councillor Bowden. I think we work well together in our different roles. I think, though, you've got this wrong on this occasion. I think it's been completely proper to challenge again on public health underspending. I don't criticise you at all on that, but 0.3% underspend I think it's damn good. And I think that shows that the interest the committee has put on this has actually got through. But Val will speak for herself in response to that. On the other hand, and this is not a personal criticism of Councillor Bowden or anyone else in this committee, for me, a £4 million underspend on adult social care is significant. And it may be percentage-wise, I hear Councillor Seif, it may be percentage-wise that it's still within margins of error, according to some, but £4 million is a hell of a lot of people's services, a hell of a lot. And I think we should be worrying about that much more than the Public Health Reserve shortfall. It's legitimate to ask the question, and I don't criticise it. But I think and I know that Patrick, he may speak, but I know that he's asking officers to evidence, is this really lower demand or are we missing demand? And I couldn't support him more on behalf of the members, because I think we do need to ask that question. And I totally support what I know he's saying to officers that work within our service. I think the independent living scheme slippage on the capital programme is in this report, Justine. I think it's the same report, isn't it?
So it's in this report because this is the year-end report, but in the other report that's coming next, there is the recommendation for you to endorse the carry forward.
Okay, I'll wait on that. So just the point about the adult social care underspend I want to make in relation to this report. Those are all the members' contributions. Justine first.
Thank you. Okay, so how does the budgetary control system work? I'm going to try and do this in a really, really brief way. So obviously it starts with business planning, and this is going to kind of come back to Councillor Howard's point as well. So when we do the business planning, particularly when we do the demand estimates, we are estimating what we think the trends will be in the numbers of people we see. So obviously the budget envelope doesn't decide who gets service and who doesn't. That's all done on care assessments and people meeting the criteria. So we can overspend on some and underspend on others, and we often do. It's very difficult to get that precisely right in business planning. We are monitoring that really, really closely all through the year, every year. Particularly in the older people field as well, you've got a whole group of full costers in there. So people who we commission services for, but they pay themselves. And obviously, therefore, the income that's generated by that is something else we also have to monitor. There's a huge amount that goes on in there, and I'd find it almost impossible to get to a zero balance at the end of the year. You're always going to get some ups and downs. Last year, we did see LD overspending, as it has done for a number of years. We know that's an area of pressure, mental health an area of pressure as well. Older people, I think we're still trying to work out what the trend should look like post-COVID, because COVID did really shift the way that looked. And so I think a lot of that underspend really is about us still not the older people bit being forecast more growth than we're actually seeing. I mean, we're seeing a shift in growth as well from residential to domiciliary care as well at the same time. You have got some big offsets in there as well, though. We have got quite a lot of vacant posts that have helped to bring that down. That's not an active thing that we've done to try to save costs. That is a consequence of just turnover in staff. But yes, there is a lot of balancing goes on there always. In terms of the bad debt provision, so the bad debt provision is calculated centrally by corporate finance. The entirety of the increase in the bad debt provision for last year was to do with adult social care debt. And that's why that charge has been put against adult social care debt. And that debt provision is worked out on the age of debt and all sorts of other things as well. It's quite a complicated calculation. Coming to Councillor Bowden, just what I would say, Val will talk about public health in a minute anyway. I think it'd be fair to say the Public Health Directorate worked really, really, really hard to get that underspend down as small as possible, and to particularly where GPs couldn't deliver services, to do other things, to find other providers who could. A huge amount of work went in to get that down. And in my mind, it's a small amount of money. I couldn't have predicted it, what the number was going to be before the end of the year. And so it feels like we've done a lot. We do probably also have to have a little bit of a conversation about, do we want to commit all of the public health reserves, or should we have a small balance that's held back just in case something unexpected happens to the public health grant in the future? But that's a conversation we can have in due course. But that's all I was going to say on public health. Thank you.
On one of the hottest days of the year for a rainy day. Val.
Thank you. I think Justine fully described our activities over the past year. We did try really hard to plan ahead, anticipate, and we repurposed, as Justine said, quite a lot into other providers. And I think partly that underspend also represents some staffing vacancies as well, which arose from decoupling from Peterborough and so forth. And I think to take Justine's point, we never know what's around the corner in terms of not just the public health grant, but public health generally. And so I think there is a discussion around contingency planning as well. But certainly I can always think of loads of investments for strengthening prevention particularly.
And the 4 million underspend on adult social care. Patrick, anything to add?
No, I just think Justine's team can't praise highly enough both Justine and the support that they give us. But a lot of the responsibility as budget holders sits with myself, with Val, with Donna, with Kirsten, with Shauna, with Will's team, and we actively track the budget. We look at our activity, we look at the spend. We have regular meetings every month. We are signing off our commitments, but then we look at it as a whole because, as Justine touches on, a lot of our forecasts, we work with people, and people's lives don't always follow what forecasts say. So hence you do get changes, you do get variances, and it's how we together work out the best way that we can smooth those variances. So as you look at the detail in the report, you will see variances against individual lines, but overall, we were very proactive to support the corporate challenge around making sure we got a balanced budget, but we also had some opportunities through some individual grant monies and some moving some one-off monies around that gave us the 4 million overall, the 4 million underspend.
Thank you. The recommendations are to note the report, 1, 2, endorse. Am I reading the right report? I'm not. I'm ahead of myself. I knew I was. I really apologise to the committee. On this, it's to note the report. Everyone happy? Anyone against? I apologise. I have got ahead of myself, which is unlike the committee agenda today, which is where I'm well behind. I apologise again. We now go to the May 2024 report, which is the later report that I announced earlier. I apologise that I mixed the two reports. Justine again.
Thank you. And I envisage I will get questions on why there is a zero forecast for adults and a zero forecast for public health. So I'm going to try and cover that off right from the start. So what I would say is it's really early in the financial year. I've tried to set out in paragraph 3.1.2 the kind of things that we're trying to deal with at the moment and to forecast forward. So we know we've got a challenging set of savings targets for 24-25. Some of those targets are well underway, but others are taking a little bit longer to put those full sort of delivery of savings in place. Demand is difficult to predict. We're seeing LD, a little bit of pressure already, but older people perhaps the other way. Again, we need a little bit more time to see how those flows pan out as we go through the year, because it's some quite significant shifts since the end of March, which don't tie in with our normal trends. Recruitment remains challenging, both in adults, but also public health in the short term. With the separation from Peterborough, there's particular risk around the staffing costs in public health. And then providers, we're still seeing pressures in the provider market. We're still seeing demand for inflationary uplifts and the like, which could potentially cause pressure. So there's a lot of things going on there, that some of which balance each other off. And so that's why there's a decision was taken not to try to put in a forecast at this stage. There will be one for June, because when we do June, you'll get all the savings monitoring on all the trackers and everything else, and we will be putting numbers out in terms of where we expect to get to on a lot of those. But at this stage, there are offsetting, balancing things, and we're just waiting to see those trends emerge a little bit more. In terms of the report itself, so there's 2 areas in the paper that committee is asked to endorse. You looked at the sexual health paper much earlier on in this committee that asked for additional funding. The committee is being asked to endorse the use of 200,000 of additional public health funding that was built into that paper. And that will then go on to Strategy and Resources and Performance Committee for final approval. And the same with the capital budget movements. Councillor Howitt, you've already asked about the ILS. So you're being asked to endorse the roll forward of the ILS money that wasn't spent last year, to endorse the rephasing of that same scheme because of further delays in terms of the site. But I'd also like you to note the additional dedicated disabled facilities grant that's now assumed through here. So we got additional disabled facilities grant last year, and it's been announced again for this year. Just to note, that's the grant that we receive, but we have to pass it on to the districts, but it helps for housing adaptations for people with disabilities. So it's a good news story for the people of Cambridgeshire that we've got that additional funding. Happy to take any questions.
Thank you. Councillor Bowden.
Thank you, Chair. I must apologise to Justine that I'll disappoint her in not criticising and questioning the zero projection so far as the outturn is concerned. We're merely going on the first 2 months here, and it's not even a full 2 months because of the way in which we do our budgeting. It's not as though we do an accruals exercise at the end of May. So it's even less than 2 months worth of data. And unless there was something really clear at this very early stage which needed to be brought to our attention, I think it's appropriate not to spend time unnecessarily making guesswork about something without sufficient data. I do look forward, when we have the end of June information, I do look forward to some analysis then, which I'm quite confident won't come to zero. But I fully support what's being done here, because otherwise it would be an academic exercise of very little value to us at all.
Thank you. On the independent living scheme, clearly this programme has cross-party support, and so I know there is concern at the slippage that's taken place right across this committee. We can't solve that here in this meeting, but I think the resolve to still act on the Princess of Wales site is still there. It's going to be later than we all hoped it would be. We appeal to our NHS friends to do what they have to do at their end. But it does come back to what Councillor Slatter and I were talking about earlier in the meeting. The model that we had just isn't working, and I think we have to acknowledge that. And its land costs and its construction costs since the big hike in inflation that has really done for that. I think perhaps we could have noticed it earlier, in truth. But nevertheless, Patrick's on top of it. And this idea that we think again what we're doing in terms of housing support and then come back with a paper is the constructive way of dealing with that, rather than just moaning on about slippage in the programme. And I think what Justine brings forward is just practical fait accompli, really. It's just a reflection of what's happened, and to make sure that our capital programme is reordered accordingly. And we certainly couldn't spend underspent capital monies in the sort of time scale that would make a difference. So I think it's the right recommendation that I think goes to Strategy, Resources and Performance, but that we like to hear and see here first. So I support the recommendations in this report, but I wanted to explain that background to them. Justine.
I don't think there were any questions, but thank you to Councillor.
Yes, sorry, did Councillor Staunton want to yeah, I miss Councillor Staunton. I'm really sorry.
I'm sitting too close to you, Richard. Yeah, Justine mentioned it was a phrase, and I think it comes up quite regularly. Recruitment is a challenge, I think, was the phrase. Where is it a challenge is anything being done specifically to deal with the challenge? Is this a wider issue? Is it something for this particular paper, or should we be looking at it elsewhere? I just want to have a bit more information behind that phrase, recruitment is a challenge.
Please, apologies to Claire. I'll call you that. I'm getting a bit tired, sorry. Justine.
So I don't know if Patrick wants to pick up that question, but certainly there's a social work apprenticeship scheme that's being looked into. There are things going on to try to improve the recruitment position. But Patrick, do you want to take that one?
Yeah, so we are, it is an area of focus for us around the volume of vacancies that we carry and the need to make ourselves more attractive. So we are, colleagues within our HR team are looking at a kind of a regional basis of how competitive we are, not just about salary and wages, but terms and conditions and our opportunities for further development with people, particularly in professions where we struggle to, and social workers for us is a challenge, but we have other professions in the council where it's a challenge. So we continue to work around that. Then as Justine touches on, we also have the social work apprentice scheme, which we are looking to grow so that we can make the offer for people to who have experience but want to become professionally qualified and continue to be employed. And during that, they do that apprentice scheme. And what we're doing is we're using some of our monies to backfill those posts. So we've got some cover whilst it gives people that time to spend during their studies and their placements.
Just follow that up. And is there a good internal promotion, internal training and promotion program, and moving across jobs and across disciplines? What is there available for that kind of thing?
Hi, I think once we've got people with us, most of our staff would report that we've got a really robust professional development offer. We've got a great learning and development team, and for colleagues who deliver, for example, hands-on care and support in our in-house services, going back to an area of interest for Councillor Slatter, we deliver a really robust care certificate and progression opportunities. I think some of the challenge is the churn in the workforce and attracting people in the first place. And as Patrick says, we found actually the apprenticeship is a really good way of doing that, because we can bring people in, grow our own, and then people tend to stay with us. So we're trying to maximise the opportunities around that.
My memory is we did have a workforce paper in the last year that had some really good stuff in it, and I guess that we will come back to it in a committee paper, because the workforce is such a key issue in us being able to deliver. So I thank Councillor Daunton for those questions. We have some Councillor Howell, I apologise, Councillor Howell.
Thank you, Chairman. Chairman, I think it'd be fair to say we've always had problems with recruiting, not only at the very basic level with somebody first entering into the profession, right through to mental health practitioners at the top end as well. And it's just the nature of this particular role of all counties all across the country. And we just have to accept, we're just going to try and sometimes be better than others. Sometimes we are, sometimes we're not, and others come along with something else and pinch some of ours, but then again, we pinch some of theirs as well. So it's an ongoing struggle that we're always going to have. And, it's just the nature of that particular profession.
Those points are well made, and I don't think need to reply, but we've always got to be ahead of others, in my view. That's what we have to aspire to do. The recommendations are to note the monitoring report, to endorse the use of £200,000 for sexual and reproductive health services, subject to the agreement of Strategy, Resources and Performance Committee, and to endorse the proposed capital movements set out in section 3.3 of the report, and again subject to the agreement of the Strategy, Resources and Performance Committee. Nod at me if you're happy with those. Anyone against? Unanimous agreement. I'm being asked to speed up by my vice chair. She is right. She is right. Can we have fairly, and I'm going to take items 11 and 12 together and ask Patrick, then Val to present and take combined questions on both as a way of speeding up. So items 11 and 12 together, Patrick.
Yeah, thank you, Chair. I'll try and summarise, and I think section 3.1 is probably the best paragraph to draw committee's attention to. So overall, the current performance is that we still continue to have new contacts within adult social care, 100,000 population, but we are lower than the financial year 22-23. We've got some really good outcomes for people who will be able to access preventative or low-level community support, which means that we don't have an ongoing future financial commitment, and those people are able to continue to remain independent. People that have received a review of their long-term care and support, we remain at a lower level than statistical or national comparators. We support a high number of adults within the community compared to regional neighbours and statistical neighbours. We've got the direct payments question earlier. I won't go to that, but the slide on page 230, there's the last year's comparison, but there's also our current performance, which they've remained static, but because we've got a higher number of people within adult social care, that means that that's one of the denominators, so therefore the percentage is lower. Reablement I touched on continues to deliver successful outcomes, and we see a percentage of people not requiring long-term support. And then making safeguarding personal is embedded in our practice, so we have a higher percentage of people feeling that their desired outcomes are fully or partially met. I'm happy to take any questions, but I won't go into any other further in the interest of time.
Very concise, thank you. I should say that Sarah Bai was due to present that report and is unwell. Nothing serious, we believe, but we should extend our best wishes to her. And take it together with pages 237 to 4248. Val.
Right, I'll meet the challenge of being as brief as possible. I think that section 3.2 is our summary on the paper. I think I can note good progress across Healthy Child Programme, weight management, NHS health checks. We've reached our highest level ever, and I will attribute some of that to collaborating with the ICB. The main area of concern is our stop smoking services. We have additional funding this year, and we have a plan to taking that forward, working very much with disadvantaged groups that have higher rates of smoking.
Combined questions on both reports. Councillor Bowden.
Thank you, Chair. It was on agenda item 12. I was particularly interested in the stop smoking analysis. But before I got to that, we have 9 indicators where we're given a quarterly report and then the financial year, and we're told what the percentage is and so on, and whether it's got a red, green or amber status. And the first one of those 9 was the drug and alcohol services information. And I read that and saw that we were only being given the 22-23 information because the data was coming from the national data set and they don't release it, and we were not allowed to have the 23-24 figures. That, of course, is total nonsense, but nevertheless, that's the national rule. It's astonishing that statistics should be kept secret. Really is, but that's not down to Cambridgeshire. But we must know our statistics for 23-24, so it would have been helpful if our statistics were published for our benefit, so that we can see the numbers. Even though I fully accept that if we're talking about the national figure, the national average, that we're not allowed to say what the figure is for that for 23-24. But then all of the 9 indicators that we've got figures for all say that they relate to the quarters from 22-23, not from 23-24. Now, that may be a mistake. I worked on the assumption that it was a mistake on all of them, but it did cause me some confusion when I was going through all of that, and especially since some of the numbers didn't really add up. Indicator 53, for example, it wasn't correct that it was only 13,763 successful NHS health checks. It was over 20,000, so over 100%, but the number is just wrong. So I'm just asking if slightly more care can be taken when putting these numbers together, especially when you've got an anomaly like that 201, where we aren't allowed to have the data, so that if we can be given data for our own performance rather than waiting for the national statistics, it just would help us so that we're not 7 quarters behind in seeing what our performance is. But I eventually got to the stop smoking figures, and they are lamentable, of course. I don't think anyone would deny that the figures that we've got are lamentable. And one can, of course, make the figures look better by reducing the annual target, but that's not the issue, and that's not the real solution. My question is, are we performing particularly badly compared with the rest of the country, or is what we're seeing here something which is typical of the rest of the country? And are there better performers in other public health authorities where we could learn how they are managing to do better than we are? Because this is a consistent problem that we've got, particularly, it has to be said, I'm sorry to say, in the north of the county. And I welcome the commentary and the further work which is being done, but we've had further work done year after year after year, and we still have not succeeded in getting to where we'd want to be. Thank you, Chair.
Thank you. I'll make sure Val comes back. Any other members first? Councillor Van Ven?
In both papers, just to note where we're doing well in terms of preventive and low-level community support, just support in the community. Presumably this fits into what is called the integrated neighborhoods that we hear about in broad strategic papers and in NHS papers, but we don't always join the dots. And so I just wanted to point that out, because I assume this is partly building our integrated neighborhoods. So where primary care is working well and can help deliver, and where we have community hubs in their various forms that are able to provide that kind of support. So just to make a note. Thanks.
Anybody else? Just from me on the adult social care performance report, you know, I do think it's important that, whereas Chair, I'm pushing for things to improve and change, I should be open and say it. But it's equally important then, when we do really good stuff, to acknowledge it in public. And I think there was a big imperative around pushing up the reviews and assessments because of the backlog. And the performance that is being reported here is really good. Clearly, we have to keep it up. But I just want to publicly acknowledge the exceptional effort that has gone into this, and it really has achieved results, and to congratulate you, Patrick, and all in the service for achieving that. In terms of questions, it was to Val.
Firstly, I think the 22-23 officer comparison, you hear me? It's in that first column. So in fact, the example you gave of health checks, that is the total for 2022-23, and then the subsequent columns are for this year. In terms of the drugs and alcohol issue, the data goes directly to the centre where they clean it, and they are very, very protective about it. Like we could release data, but then they might come along and clean it, and it might be totally different. And that's why they are very reluctant to let us put any data out into the public arena, at least.
I suggest we pick that.
Yeah.
It's a good debate,
Yeah,
actually.
yeah,
Can I
it is.
suggest we put it on the
Yeah.
spokes agenda
Yeah.
and tease that through a
Yeah,
bit
yeah,
more?
it will. It's we challenge it all the time because it's very frustrating. But it's partly because I think the data is not only monitored by the health side, but also by the Home Office as well. So there are certain sensitivities that relate to this type of data, I'm afraid.
But what powers we might have to vary that,
Yes.
I'm sure, is
Yeah.
what Councillor Bowden was raising. So
Yeah.
let's take that on. Do you mind if I push on to try and finish in time? All right, 30 seconds.
To just ask, are there any health authorities around the country which are doing better than us on the smoking side, where we could manage to get some clues as to how we can manage to do better?
Sorry, that was a substantive question. I apologise, I overlooked it. Yeah.
Absolutely. We work very closely with our regional partners, but more widely in that. I don't think we are any worse, because I think all of us have been affected by GP withdrawal from providing these services. So what we are doing at the moment is repurposing them, and that's very much what we are doing with the new money. What we did last year, and the situation that Justine described, where we repurposed the money, and a lot of it was the smoking monies, which we repurposed into other providers.
And I think it's
continue
important
do
to
that.
say we only agreed a new strategy on this last year.
Yeah.
And it's bound to take some time to see how effective that is.
Yeah.
But I'm sure that will be coming back to this committee. The combined recommendation, so we're asked to note both reports. On the adult social care report, we're asked to agree the proposed changes, and on the public health report, we're asked to support the actions undertaken for improvements. People happy with that? Yeah. Anybody against? Agreed unanimously. We're nearly there, folks. Please bear with me. I'm sorry it's taking a bit of time. Training plan and committee appointments. And the committee agenda plan. We'll just take them one by one. Tamar, on the committee agenda plan first.
I sent round a revised agenda plan the other day, but I didn't know obviously that's continually updated, so there'll be another update in the next few weeks.
Okay, thank you for that. And Patrick, I know that you wanted to just say something about one item.
Yeah, so we are reviewing the agenda plan to make sure that we've got all of our forward plan agenda items. The public health team have had to move some around, so moving them from October into the later year. And we're undertaking the charging review at the moment, so we expect to bring the recommendations and that back. Ideally, we're aiming for October to bring that paper back.
Thank you very much for clarifying for that. Anything on the agenda plan? Chris, sorry, I have to call you Councillor Bowden.
Thank you very much indeed, Chair. Just my request to you, Chair, would you just check with officers going through this list that we've got in front of us to ensure that we're not being scheduled to have discussions about commissioning, which again are too close to the end of a contract. So if you'd be kind enough to check that with officers outside this meeting, I think it would be really helpful to us.
Okay, could that be minuted, please, Tamar? And again, we can look at it as spokes, but it's a perfectly proper request for me, and I'm happy to agree to it. Can I just say we're not planning to use the reserve day in September, just so you can know that for your diaries. On the training plan, Tamar?
Again, I know that Patrick has asked officers to review and work on a revised training plan, so that's ongoing at the moment.
Councillor Van Ven?
I guess we might pick this up at spokes, but and I think there is some care together stuff that's meant to go into the training plan. And I wondered about something ahead of the charges review paper. We had a good session on how care packages are put together, but it might be helpful to have something more on assessments and yeah, thanks.
Just on care together, so the minutes don't mislead anyone. Our real proposal originally came from Councillor Van de Ven was for a authority-wide training opportunity on care together, not another one for members of this committee, but it's hit the buffers a bit. But that's what we're asking to be explored, just to be very clear. But there are some rules issues that are making that difficult, I understand, but we're hoping that might be resolved. On committee appointments, I don't think this needs introducing by Tamar, unless you want to introduce it. No, I am going to go through the health liaison groups and to ask for volunteers on each one, just because we got new members of the committee, but also we hope some existing members of the committee may choose to join them. So I'm looking here at page 257 of the committee papers and the pages that follow. The Cancer Research Hospital, any other volunteers? For the people already there, you don't have to volunteer again. We'll take it as read unless you withdraw. But any additional people for the Cancer Research Hospital Engagement Board? Councillor Slatter, thank you. Okay, so that's a third member there. Great. All Liberal Democrat there. Anybody else from? And we love the Liberal Democrats. Oh no, I'm not allowed to say that today. I'm so sorry. But anyone from other groups?
It only has 2.
Oh, we're only allowed 2. I'm sorry, Councillor Slatter. I'm really sorry. The next one, Cambridge University Hospitals. I believe I'm on that, so I volunteer for that. Oh, that's the trusteeship. I'm misreading it. I do apologise. Right. Does it start at the fact? CPFT? No, because that's Councillor Daunton. Sorry, it wasn't page 257. It's page 2. They're governors. I'm taking governorships when I should be taking liaison groups, and that's my error. So I now move to page 261. Sorry, people. Page 261, the Children's Hospital Liaison Group. It can't be Councillor Boulat now because she's come off the committee. Yep.
It's not actually liaison group. It's an invitation by the Cambridge Children's Hospital, which doesn't exist yet, to keep us in the loop, but it is not a formal liaison group.
Okay, but that doesn't
But we
prevent
need another one.
Doesn't prevent someone who's interested in the Children's Hospital from volunteering, Councillor Daunton.
Well, given that it's going to be including children's physical and mental health, it's probably something that I should be interested in, and indeed I am. Yeah.
I think it does no harm to have the list as long as the minute explains what Councillor Van de Ven said. Anyone else?
Chair, may I suggest we could have substitutes, because if, for example, Councillor Daunton couldn't go, we don't want to show lack of interest or involvement.
It did come actually up, Tamar, whether we have substitutes or not. Can you just remind me of the answer? Can Tamar remind me?
I'm
of the
not
answer?
clear. I can't recall the answer at this moment in
Okay,
time.
can we just park that? Let's get the volunteers today, and we can come back and clarify that later. Okay, the next one is Cambridge University Hospitals. We've got 3 already. Anyone additional? Oh, great. Keith is putting his name forward, so that's very good. Is it not? Is it absolutely? I thought these were fairly informal meetings where the numbers weren't limited. Am I not right in saying that, Tamar?
I don't have the answer to that. Sorry.
So I'm ruling that from the chair. So that's Councillor Prentice to be added to that. Anyone else? Next, Cambridge Community Services Foundation Trust. Anybody?
Yes, I'd be willing to do that one, Chair.
Well done, Councillor Black. Well done. Anyone else? No, thank you very much. The next one is the Cambridge and Peterborough. I'm getting confused again. That's community services. This is CPFT, mental health. Anyone here like to do CPFT? Councillor Murphy? Can I take Councillor Murphy first? I'll take both of you. You think there's a maximum? Okay.
I was just about to say, I think we've got the maximum already.
Okay.
Yeah.
As I say, I'm not sure that is a correct rule. So can we at least note where we're exceeding the notional maximum, the interest, and can we take Councillor Murphy's interest in that? And I'll clarify that with the officers after the meeting. The next one, the East of England Ambulance Trust. Councillor Murphy and Councillor Taylor and Councillor Black. I got this set up. There's definitely no maximum there. So let's take all 5 of those. The next one is the one with... No worry, that was Councillor Taylor, Councillor Black and Councillor Murphy. Did I remember that rightly? Yes, being added to the people that are there at the moment. Those were all on the ambulance service. Just listen, don't try not to interrupt, Susan. Okay, you want this to be finished, let me do it. The next one is the ICS and Health Watch Liaison Group. Councillor Black? Anyone else? Right, Councillor Black to be added to that. The next one is essentially Hinchinbrook. Councillor Prentice, anyone else? Councillor Prentice is added. And Papworth, Heart Hospital, National Specialism, and Lungs. Anyone? Okay, Susan and I will carry on doing that. I'll clarify the numbers afterwards, but I would very much hope that all the members that have volunteered are able to do that. Are all of the other appointments that you see before you? Oh, sorry, I should just ask, does anyone want to change any of the contest or pull out or any of the other appointments that we see? Councillor Bowden.
Thank you, Chair. I just wonder if in future it may be possible to include QEH in the lists which we've got here. And whilst I appreciate the QEH is outside the county, it nevertheless serves residents who are within the county. We have a liaison group and Councillor Van der Ven has kindly agreed to join that. And whilst that may be organised by Fenland District Council, it still does relate to the health needs of residents of this county. I just think it may be helpful to include it in future lists.
I strongly support that. It is in cooperation with Fenland District Council, and the table would have to show that, and where we're happy that they're our leading partner and we're cooperating with them. But the idea that we can ask for volunteers here, I strongly support that. Okay. Yeah, exactly what I've just said. Calm. But I just have to deal with the other appointments and make sure people are happy with them. Anybody want to change any of the other appointments in the agenda plan? Okay. Right. So are all the other appointments agreed? They are. Can I just say, Tamar Oviatham has been working with us for 3+ years, and probably before that, and before my time. But because of changes in democratic services, she's going to be moving to CYP committee and the Fire Services Authority. Tamar, I thoroughly enjoyed working with you. You say you're going to be embarrassed if I say any more, but on behalf of the whole committee, thank you for working with us so intensively, and good luck. And of course, we'll see you a lot, including at full council, in your future role. Rashenda Greenhill, who has been doing health scrutiny for us, is also going to do the morning public health and adult social care. So Rashenda will become our full-time democratic services officer. But thank you warmly to Tamar. Our next meeting is the Thursday, the 10th of October. I'm 12 minutes over. You can slap my wrist, anyone. But everyone has observed the rules today damn well. I think we've reflected our commitment to this council really well, and I thank members on all sides of the chamber for doing so. The meeting is closed. That was exhausting.